Assalamu alaikum wa rahmatullah. Good morning, dear colleagues and fellow.
Excuse us if we started.
Not yet.
Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullah. Good morning, everyone. Glad to have you here today and we'll have our annual thoracic malignancy. This meeting, we used to have it annually to discuss the update in lung cancer and thoracic malignancy. And the main objective is to present the latest advances in management of lung and other thoracic malignancy. So we're targeting medical oncologists, nurse specialists, nurses, our colleague in radiation oncology, and the surgeon as well. So this is scientific and organizing committee. The attendees will be handled and receive CME hours from Faisal University. This meeting is a one-day meeting. We'll be having 3 sessions. We'll have session 1 and session 2 followed by a break, lunch break, and then we'll come back for the last session. Without further delay, we're gonna start with the first session for today, and it will be chaired by 2 dear colleagues, Dr. Turki Al-Faya. Dr. Turki is a well-known consultant of adult medical oncology. He's well known by his talks and participation in different meetings, national and international. And Dr. Walid Sawi, from also a well-known consultant, medical oncologist from King Fahd Medical City, Dammam. Dr. Turki is a consultant at National Guard Riyadh, and they will start the first session for today. And the first session will be mainly about improving the outcome of early stage lung cancer. Dr. Turki and Dr. Walid, please.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Nafisa, for kind invitations, and congratulations for yesterday, and hopefully today we will discuss very nice selection of the topic, and really that is how is evaluations and revolutions in the lung cancer. I think we have eminent speakers to talk today about the first session, and then the session after that. It's my great pleasure to moderate this session with my dear friend Dr. Turki Al-Faya, as a consultant medical oncologist at National Guard Hospital. And we'll start with the first talk of our session is the perioperative versus neoadjuvant nivolumab for resectable non-small cell lung cancer. We'll talk about with Professor Mohsen Mukhtar. He's well-known clinical oncologist. He from Cairo. I think the first he's recorded presentations, and he will join us in the discussion. Yes.
Assalamu alaikum wa rahmatullah. Good morning, dear colleagues and fellows. I'd first of all like to express my gratitude and pleasure to be with you, and thanking Doctors Ashwaq, Nafisa and Kanaan for inviting me to be part of this lung liver masterclass, and Dr. Walid and Dr. Tawfiq for their kind introduction. Now, starting off the day with a very exciting hot topic in non-small cell lung cancer, whether we should be giving full perioperative or is it just enough to give neoadjuvant for resectable non-small cell lung cancer. So these are my disclosures. I wanted to start you off with this very busy slide. 2 trials of adjuvant therapy, though I believe that adjuvant therapy should only be given if the patient was not given neoadjuvant by mistake. Then we've got a clinical trial dedicated to the neoadjuvant, 3 cycles of Nivo chemo. That's the 816. And we've got a robust number of clinical trials taking perioperative. So neoadjuvant up to 4 cycles, followed by an adjuvant period of around 1 year in terms of a PD-1 or a PD-L1 inhibitor. What we can see from this slide is that There is a slight difference in the inclusion criteria. So resectable 1B to 3A in the Checkmate 816, while the perioperatives went up to stage 3B. Platinum doublet was used in all the clinical trials, carbo or cisplatin, except for the Keynote 671, which allowed only cisplatin. EGFR and ALK patients were included, though today I believe no one would include these patients in those clinical trials in some of the perioperative. So looking at what we have in terms of consensus, and the consensus will tell you that any patient with a 1B, so tumor more than 4 centimeters, consider that neoadjuvant immune checkpoint inhibitor combo with chemo up to stage 3, and then consider giving adjuvant chemo and or an immune checkpoint inhibitor from this consensus. So why are we talking about neoadjuvant or sandwich? Well, the neoadjuvant portion clearly aids in early eradication of the micrometastasis. And the second, I think, most important thing is that presence of that whole tumor, allowing for an activation of a broader and more diverse immune response, while the post-operative portion of the immune checkpoint inhibitor allows for pre- and post-treatment tissue to adjust treatment, as for example, something like the PCR. Other tumor biomarkers that can guide therapeutic decisions, including something like clearance or non-clearance of a circulating tumor DNA. So if we look at these trials in terms of some of the results, and we look at the event-free survival, let's discard the adjuvant, but look at the perioperative and the neoadjuvant, because event-free survival was a primary endpoint in all of the clinical trials, and we can see that it is in the range of 0.6. With different maturity data, the Keynote and the Checkmate 671 and the Checkmate 816 having the most mature data up to now, and these will tell you that the event-free survival is in the range of around 40 plus months for. So I know we're not supposed to do cross-trial comparison, but essentially when we have a patient in front of us, that's what we do. So I'm going to focus on the 816 and the 77T because they both had nivolumab as that checkpoint inhibitor being the backbone with the chemo. They have some differences. The 816 took patients from 1B to 3A, while the 77T went up to stage 3B. The 816 had 3 cycles pre-operative with optional chemo and or radiotherapy post-operatively, while the Checkmate 77T gave 4 cycles pre-operatively and no chemo was allowed post-operatively. It was just nivolumab. Carboplatin was allowed in both trials, 20% in the 816 and 75% in the 77T. And both trials included squamous cell carcinoma and excluded an EGFR or ALK fusion patient. If we look at this in terms of graphs, what we can see in the Checkmate 816, event-free survival, as is with probably all the perioperative, in the range of 0.6. There are only 2 clinical trials that have mature data for overall survival. The hazard ratio in the 816 is 0.72, while in the Keynote 671 it is 0.73. The other clinical trials have not had a mature overall survival. But one of the things to notice is that the PCR rate is greatly increased by that new adjuvant portion of immune checkpoint inhibitor chemo combination. So what have we learned from these 6 phase 3 trials? 1, PCR greatly improves and significantly improves for up to 20%. The addition of the perioperative PD-1, PD-L1 inhibitor improves event-free survival. 1 in 5 patients who undergo neoadjuvant chemoimmuno will not make it to surgery, and I think that is something that you need to discuss with your patient. And another thing, that achieving PCR or circulating tumor DNA clearance is predictive of improved survival. So let's dig deeper into the 816. The 816 stage 1B to 3A according to the 7th edition. No ALK, no EGFR mutation included. Nivo chemo every 3 weeks for 3 cycles versus chemo for 3 cycles. Surgery within 6 weeks after that therapy, and optional adjuvant chemo plus minus radiotherapy with a follow-up. Looking at PCR, event-free survival, and having overall survival and major pathological response as part of their secondary endpoint. If we look at the PCR and the updated 4-year event-free survival, we see that the PCR shoots up from 2.2% to 24% with the addition of Nivo for those 3 cycles. Also, the event-free survival at 4 years is increased by 11%, going up to 49% in that Nivo combination. Remember, only 3 cycles of Nivo chemo. What about overall survival, whether it is lung-specific survival or in total overall survival? We see an increase of around 11 and 13% specifically in this combination versus chemotherapy on its own. And the 5-year final overall survival that was presented in the ASCO at 60 months, 7.72 in terms of hazard ratio, 65% of the patients on the Nivo chemo were surviving versus 55 on the chemo alone. Remember, a lot of those patients, when they had a recurrence on the chemo, were subjected to some sort of checkpoint inhibitor. But what about the perioperative? Has it done anything more than just the neoadjuvant? And we see that the perioperative trials, in essence, gave IO plus chemo for 4 cycles, surgery, then an IO for 12 to 16 cycles. The Keynote 671, the AGAN, and the Checkmate 770 have reported data. As I said, they all took patients from stage 2 to 3B. ALK and EGFR was allowed in some of the trials, and carboplatin was allowed in the AGAN and the Checkmate 770, but not in the Keynote 671. If we look at them in terms of PCR rate, we see that, again, it is in the range of 20%. The event-free survival hazard ratio is in the range of 0.6 for all the clinical trials. And if we look at the latest overall survival data that we have from these clinical trials, the Keynote 671 in the ESMO IO last year gave us a hazard ratio of 0.73 with 68% of the patients alive at 4 years. So what about the data from the 770? Because this is the one that uses Nivo, and you can probably compare it to the 816. That hasn't reported a final overall survival, but they gave us some hint in terms of overall survival and lung-specific survival in the ASCO this year. 0.85 in terms of hazard ratio for overall survival, and for lung-specific survival, 0.60 for the Nivo versus the placebo combination in the 770. So can we compare them? The 816 versus the 770. If we look at event-free survival, the hazard ratio in the 770 actually looks slightly better, 0.58 compared to 0.68. So in essence of around 10% difference in terms of hazard ratio benefit. But that can't be something that we do without comparing it in terms of a weighted analysis. And the comparison of the neoadjuvant Checkmate 816 versus the perioperative 770, landmark event-free survival from definitive surgery. This was a weighted analysis. The perioperative versus the neoadjuvant, we see that the hazard ratio here is 0.61, so probably favoring that perioperative Nivo combination rather than just the neoadjuvant for these patients. So when a patient with resectable non-small cell lung cancer comes to your clinic, what do we ask ourselves? Are all the perioperative combos similar? Should I be giving the perioperative even in 1B in stage 2? And is perioperative superior to the neoadjuvant only, which is the question. Perioperative regimens, they all look similar in terms of event-free survival, hazard ratio, as we can see here. Standing out on its own is the new torch with a hazard ratio of 0.4, but in essence, it's in the range of 0.6. Is perioperative superior to neoadjuvant only? I'm going to dig deeper, looking at PCR and major pathological response. What we take from this is that around 20% of our patients will achieve a PCR, and less than 50% of the patients will achieve a major pathological response. Now, is that important for the survival of these patients? We know now that complete pathological response is a surrogate endpoint for neoadjuvant immunotherapy in clinical trials for non-small cell lung cancer. This meta-analysis shows us that the difference in event-free survival in patients who had a PCR versus patients with no PCR, the hazard ratio is 0.23 with a p-value of less than 0.0001, showing us the importance of achieving a PCR in our patients. And how can you get that? Does stage matter? And I think that is something else to be asking ourselves. The data from the 816 shows us that PCR by baseline stage of the disease, it was higher in the 1Bs as compared to the stages 2s and 3. I think that is important also when considering what type of therapy, whether it's neoadjuvant or perioperative for your patient. And we can see from both the Checkmate 816 and the Keynote 671 that PCR does make a difference in terms of event-free survival. Patients with a PCR hazard ratio from the 671, 0.33. In the Checkmate 816, it was actually 0.13. And patients without a PCR from the Keynote 671, the hazard ratio is 0.69. Now, if we take that, what should we be doing with it? Hazard ratio for patients who achieve a PCR, 0.33, non-PCR, 0.69. So if the PCR group is benefiting so much, shouldn't they continue? Because they still have a more than 20% chance of recurrence. What about the non-PCR group? If there was no PCR and this patient hasn't responded as well, should they get a different type of therapy or more intensified therapy? And I think that is a question of a lot of clinical trials ongoing. So should we continue immune checkpoint post-operatively for everyone? 816 versus the 770. Now what they showed here, patients with a PCR and no PCR in that weighted analysis. The hazard ratio for patients with a PCR in that weighted analysis, 0.58, no PCR, 0.65. And from that, we got a lot of controversial papers. We have papers that were published this year in January, one paper telling us adjuvant immunotherapy should be used in patients with non-small cell lung cancer with a pathological complete response to neoadjuvant immunotherapy. And a very contradicting paper, adjuvant immunotherapy should not be used in patients with pathological complete response to neoadjuvant chemoimmunotherapy. So I think the verdict is still out there about what to do with these patients when they do not achieve a. So what else can play a role? I think circulating tumor DNA clearance is again of importance. If we look at circulating tumor DNA clearance from the 816, we see that the combo gives you a 56% circulating tumor DNA clearance. And the data in terms of overall survival shows us that patients with a circulating tumor DNA clearance, the hazard ratio versus patients without a circulating tumor DNA clearance is 0.31 in that Nivo chemo combination. What about the 77T? What it did show us was that during the post-operative period, circulating tumor DNA clearance was more likely in the Nivo arm, so recurrence was 8% versus 20% with the placebo. And this is regardless of whether the patient had a PCR or not. It was 4% if the patient had a PCR and 14% if the patient had no PCR, compared to 20 and 21% on that placebo arm in the 77T. So that also tells us that even when your patient has a PCR, that perioperative portion of, or the postoperative portion of the immune checkpoint inhibitor will decrease the circulating tumor DNA recurrence. So having all that data, can we put a conclusion to whether it is neoadjuvant alone or perioperative? I don't think we do have that answer fully yet, but when you do get a resectable or even potentially resectable patient, deciding on that, will stage come into consideration? If you've given the neoadjuvant portion and you achieve a PCR, should you omit the postoperative? If you planned for perioperative and achieve the PCR, should you omit the adjuvant phase? And is there a role for circulating tumor DNA? Well, I'll give you my take on what I do in the clinic. If I get a patient with a stage 1B, I will tell them that we might only be giving that neoadjuvant portion if they achieve a PCR. But otherwise, it is always telling the patient that there is going to be a setting. Because even if I achieve a PCR and I know that there is benefit for continuing that immune checkpoint inhibitor post-PCR, I think if the patient is well tolerated and there is no financial burden on that patient, I think giving that post-operative therapy is still of importance for the patient. Will circulating tumor DNA come in play? If my patient achieves a PCR, negative circulating tumor DNA, and he has some toxicity from the immune checkpoint inhibitor, then that is the only patient I would be inclined to stop the post-operative adjuvant phase of the perioperative setting. And with that, I'd like to thank you very much for
I'd like to thank Prof. Mohsen Makhtar for this excellent review of this hot topic. We would like to move to the second session. The speaker is Dr. Hamid Al-Husseini, our consultant medical oncologist from King Faisal Specialist Hospital. He will give us the 5-year update of CROWN trial using lorlatinib as a frontline therapy in ALK-positive non-small cell lung cancer.
Assalamu alaikum. I'd like to thank the organizing committee for arranging this exciting masterclass. So I'm going to talk specifically about CROWN trial 5-year update. So this trial is looking mainly comparing lorlatinib versus crizotinib in a treatment-naive patient with advanced ALK-positive non-small cell lung cancer. So this is a phase 3 randomized open-label trial, international trial, in which 296 patients with a stage 3B to 4 ALK-positive non-small cell lung cancer, treatment-naive, asymptomatic brain metastasis, randomized either to the lorlatinib 100 milligram daily or crizotinib 250 milligram twice daily. And the primary endpoint was mainly progression-free survival by blinded independent central review, stratified according to the presence of brain metastasis and ethnicity. So at the interim analysis, and also after 3 years, there was a significant improvement in the progression-free survival by blinded independent central review. So among the patients with the lorlatinib was not reached versus 9.3 months with the crizotinib with the hazard ratio 0.27, which was significant. So the current analysis is conducted at 5 years. We know that the endpoint evaluation by blinded independent central review stopped after 3 years. So now looking mainly for progression-free survival by the investigator assist, overall response rate, intracranial time to progression, safety, and biomarker analysis. So at 5 years, there was a significant improvement in the progression-free survival with the lorlatinib as compared to the crizotinib. It was not reached versus 9 months with the hazard ratio 0.19 with a significant p-value. And this is the first time that we reach 5 years in advanced non-small cell lung cancer and still PFS not reached. And at 5 years, you can see it was 60% with the lorlatinib as compared to 8% with the crizotinib. Overall survival is still immature. So the progression-free survival benefit were consistent among all the subgroup analysis, including the patient with a brain metastasis or not brain metastasis. So among the patients with the baseline brain metastasis, you can see the median progression-free survival was not reached versus only 6 months with the hazard ratio 0.08. And you can see at 5 years, it was with the lorlatinib 53%. Among the patients without baseline brain metastasis, the median progression-free survival was not reached with the lorlatinib as compared to 11 months with the crizotinib with the hazard ratio 0.24. And at 5 years, it was 63% versus only 10%. Overall response rate with the lorlatinib was around 81% versus only 63% with the crizotinib. The complete response achieved in around 10% with the lorlatinib. When you look for the median duration of the response was not reached with the lorlatinib as compared to only 9 months with the crizotinib. Among the patients with the baseline brain metastasis, the intracranial overall response rate was higher. It was around 60% with the lorlatinib as compared to 11% with the crizotinib. Complete response achieved in around 49% with the lorlatinib as compared to 5%. And the median duration of the response was not reached intracranially with the lorlatinib as compared to only 13 months with the crizotinib. Time to intracranial progression was significantly prolonged with the lorlatinib. So the median was not reached as compared to only 16 months with the crizotinib with the hazard ratio 0.06. And you can see at 5 years, the time to intracranial progression 92% free with the lorlatinib as compared to 21% with the crizotinib. So the benefit we're seeing among all the patients with the baseline brain metastasis. So the median was not reached versus 7 months, and also among the patients without baseline brain metastasis, it was not reached time to intracranial progression as compared to 24 months with the crizotinib. What about toxicity? So grade 3 or higher adverse event occur in around 77% for a patient who is receiving lorlatinib as compared to 57% with the crizotinib. Adverse event leading to the temporary drug discontinuation, 62% with the lorlatinib. Leading to the dose reduction, 23% versus 15% with the crizotinib. Leading to the permanent drug discontinuation was almost equal, 11%. The most common grade 3 or higher adverse event was mainly hypertriglyceridemia, which is around 25%, weight increase 23%, hypercholesterolemia 21%, hypertension 12%. CNS adverse event occur in around 42%, but you can see most of the adverse event was mainly grade 1 and 2, which is around 86%. But still, I mean, dose reduction did not impact efficacy of lorlatinib in either progression-free survival and also in time to intracranial progression. So there was no significant difference. The same, when they look for a patient with a poor prognostic biomarker, lorlatinib showed clearly treatment benefit. So among the patients with ALK variant fusion 1, the median progression-free survival with the lorlatinib was 64 months versus 7 months. Among the patients with a variant 3AB, still the median progression-free survival was 60 months versus 6 months with the crizotinib. The same, among the patients with a TP53 mutation, the median progression-free survival with the lorlatinib was 52 months versus only 5.7 months with the crizotinib. When they look for the cause of acquired resistance, they found that there was the new secondary ALK mutation were not detected in the circulating tumor DNA among the patients with the lorlatinib. So it was 0% as compared to 9 to 2% with the crizotinib. So the most common cause of acquired resistance to the lorlatinib was mainly bypass mechanism, which is around 29%, and other gene aberration, which is around 35%. So in conclusion, after 5 years of follow-up in the CROWN study, median progression-free survival has not been reached, and the BFS at 5 years, 60%. The probability of being free of intracranial progression was 92% at 5 years. There was no new safety signals. Efficacy benefit was seen across all the subgroup, including patients with a poor prognostic biomarker. The BFS observed with the lorlatinib correspond to the longest BFS reported in advanced non-small cell lung cancer because it's still not yet reached at 5 years. This systemic efficacy result, coupled with the protection from the intracranial progression and absence of new safety signals, indicate that first-line lorlatinib provide unprecedented improvement in outcome for a patient with advanced ALK non-small cell lung cancer, and now become our preferred first-line therapy. Thank you.
Shukran, Dr. Hamid. Thank you. Dr. Hamid will keep the question at the end of this session. Now is also moving to not in the metastatic setting, in the adjuvant setting. Again, one of the trials that changed the practice in the lung cancer, especially in the ALK positive patients, is ALINA trial. Adjuvant alectinib improved survival versus platinum-based chemotherapy in the ALK positive non-small cell lung cancer. Our chairperson, Dr. Nafisa, she is a consultant medical oncology at National Guard Hospital. She will talk about the ALINA trial and one of the important trial that changed practice moving forward for the adjuvant setting. Please, Dr. Nafisa.
Good morning again. Thank you, Dr. Walid, for the kind introduction. So as we know, 30 to 40% of patients with non-small cell lung cancer are candidates for resection. So they come early and they are eligible for upfront surgery. But yet, however, we are seeing the advances in surgery and improvement in the treatment outcome. Still, those patients are having disease recurrence. And this range between 50 to 76%. So 50 to 70% of the patient will have disease recurrence, unfortunately, in spite of early detection and having complete resection of the disease. And this percentage depends on the state, definitely. So ALK rearrangement or ALK mutation will be found in 4 to 5% of those patients. So who are ALK patients? Those patients usually younger in age, usually they are non-smoker, and they do have high possibility to have brain metastasis. So 4 to 5% of those patients with resectable disease might be having ALK mutation. What happened now and what is new in the field of early lung cancer, there is improvement in the treatment outcome by introduction of neoadjuvant and adjuvant immunotherapy. But unfortunately, this cannot be applied on patients with targetable mutation like ALK disease. So ALINA study looked at the patient with resectable disease and then received ALK inhibitor for 2 years versus those patients who did not, with the same mutation, but they did not receive alectinib, but they received the standard of care, which is immunotherapy. So ALINA is phase 3 trial. They enrolled patients who underwent complete resection of their disease, having good performance status 0 to 1, and having good organ function. And patients were stratified by stage and race. So they enrolled around 260 patients. The enrollment was 1-1 randomization. So the first arm received alectinib 600 milligrams twice a day for 2 years, and the other arm, as I mentioned, received the standard of care platinum therapy. They received 4 cycles, and then after that, patients were kept on surveillance for disease recurrence. So the primary endpoint was disease-free survival, and then other endpoint was CNS overall CNS relapse, or CNS-free survival, overall survival, and safety. So regarding the brain relapse, they used to do MRI of the brain every 3 months with every disease evaluation. They continue doing that for first 2 years, and then every 6 months. So the ALK was detected locally, but there was central sort of confirmation for positivity, and if they could not do it locally, they sent for central testing. Most of the patient, the majority of the patient, they had their result by doing immunohistochemistry, but there were few patients had their result by NGS test. So statistical analysis, they did this in hierarchy manner. So they look at all all patients. So in the beginning, they look at stage 2 and stage 3. As I mentioned, they enroll patients from stage 1B up to 3A. But in the statistical analysis, they look at the patient initially, the stage 2 and 3A, and if that positive, they go for intent to treat population. So patient demographic, the baseline characteristic, well balanced between the 2 arms. If we are talking about age, gender, smoking status, performance, and stage and nodal status. Even they look at the surgical procedure, if it is lobectomy or other type of local resection. So the trial met its primary endpoint. So the disease-free survival significantly improved by giving alectinib for 2 years. So if we look here at the hazard ratio, it was really significant, 0.24 in favor of alectinib, and significant p-value. So the median DFS was 44 months, while for the chemotherapy arm, while it was not detected in the alectinib arm. And this was for patients with stage 2 and 3A. So when they look at the disease-free survival for intention to treat population, so all comers started from stage 1B to 3A. Again, the hazard ratio was in favor of alectinib. It was 0.24, significant p-value, and the median DFS was 41 months, and it was not reached again for alectinib arm. Disease-free survival, as I mentioned, it's not moving. Yeah. So what about the subgroup analysis? You can see here, all patients, all groups were benefited from giving alectinib. So there was improvement in disease-free survival regardless of the performance or smoking status or stage. Just I need to draw your attention, only 10% of the patient were having stage 1B, 35% of the patient were having stage 2, and the majority were stage 3, like 55% of the patients were having stage 3. So regardless of the stage, all the patients, the hazard ratio was favor of alectinib. And again, around 50% of the patients were having N2 disease, and the benefit was the hazard ratio was in favor of alectinib even with a patient with N2 disease. So this is about the stage. So what about the hazard ratio or the PFS with each stage? So if we look at the stage 1B, the hazard ratio was again significant 2.1, with the stage 2 was 2.4 and 2.53A. But again, we cannot draw much conclusion from stage 1B because the number of patients was small, but we can say clearly that regardless of the stage, there was benefit from using alectinib in the adjuvant setting after complete resection. So what about CNS relapse? So around 50% of the patients with ALK-positive disease will have, 56% will have disease recurrence down the road. So looking at those patients, you can see very clear there was significant reduction in the relapse in the brain, CNS relapse, with a hazard ratio of 0.22. At the time of the analysis, 14% in the chemotherapy arm were having brain metastasis. So 14 patients had brain relapse, while only 4 patients had brain relapse in the arm of alectinib. So what about local and distant metastasis? We can really see that alectinib reduce the local recurrence and reduce the distant recurrence as well. If you look at the brain, as we mentioned before, there was significant reduction in the brain metastasis. Also in the bone and the local recurrence, they noted that alectinib in the adjuvant setting minimized all these relapses. So what about the safety? They did not notice any new safety signals. So alectinib had been used previously in the advanced non-small cell lung cancer, and we do have 3 phase 3 trials, and even alectinib had been compared to the first generation crizotinib, and the 3 trials were in favor of using alectinib in the first line setting, including the ALEX trial. So we are using alectinib. It's advanced non-small cell lung cancer for years, and it is a standard of care for the first line since August 2023. And now, of course, as Dr. Hamid mentioned, we have lorlatinib in the first line as well. But the medication used to be safe and tolerable. So here, when we use it in the adjuvant setting, we did not see any new safety signals. Looking at the toxicity grade 3 or 4, 3 or 4 were similar in the 2 arms, the chemo arm and alectinib arm. There was no grade 5 toxicity. Rate of discontinuation and dose adjustment was higher in alectinib arm. So looking side by side to side effect and toxicity, alectinib was mainly associated with fatigue and elevation of the liver function test, and constipation, some GI disturbances, and chemotherapy was associated with more nausea, vomiting, and febrile neutropenia. So what do we have now? What we are waiting to see with alectinib, we do have 2 trials looking at alectinib in the new adjuvant setting. So Nautica trial and Alino trial, still we don't have the result, and we do have the Horizon looking with locally advanced disease, and then they compared alectinib to durvalumab after concurrent chemoradiation. So in summary, Alina is the first and the only positive phase 3 trial of an ALK inhibitor in resected stage 1B to 3A. Treatment with adjuvant alectinib resulted in statistically significant and clinically meaningful disease-free survival compared to chemotherapy with a significant hazard ratio of 0.24. The DFS benefit was consistent across all subgroups, and there was improvement in CNS DFS with a hazard ratio of 0.22. The medication was tolerable and we did not see any new safety signals. Thank you.
Thank you, Dr. Nafisa. We will move to the last session of the first part of the day. It will be a very important topic to discuss. The speaker is Prof. Ahmed Badib from King Khalid Hospital in Najran. He will discuss the role of induction or consolidation immunotherapy plus SBRT in early stage high-risk lung cancer.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Thank you, Mr. Chairman, for this kind introduction. Thank you for the organizing committee for the invitation, and I think this is important talk because we know that this is the first phase 3 trial dealing with the role of immunotherapy with radiotherapy in the early stage non-small cell lung cancer. So this trial is SWAG trial, SWAG NRG, which is randomized phase 3 trial of induction consolidation atezolizumab plus SBRT. Now we are adding radiotherapy, first SBRT alone in high risk early stage non-small cell lung cancer. This was conducted in UC Davis Comprehensive Cancer Center. So as a background, we know that stereotactic body radiation therapy is the standard of care for early stage node-negative inoperable non-small cell lung cancer. The predominant failure pattern is regional and distant, and immunotherapy improves PFS and overall survival in operable early stage non-small cell lung cancer. We have one randomized phase 2 trial suggested EFS benefit to immunotherapy following SBRT in the early stage inoperable non-small cell lung cancer. We have also several non-randomized trials demonstrate safety of immunotherapy in this setting. One of the trials, which is phase 2 out of MD Anderson, this is ISABR trial, which showed the benefit of adding immunotherapy to the SBRT, and the abbreviation of this trial is ISABR, which is stereotactic ablative radiotherapy with or without immunotherapy for early stage. And we can see from the curve that there is benefit, but it is phase 2 trial. Now we have also some okay. We have another phase 1 and phase 2 trials just to prove the concept of safety by using different immunotherapy, including nivolumab, durvalumab, and also we have another phase 1 trial, which is with the similar design to what we have in the phase 3, which using the same protocol, neoadjuvant nivolumab, 8 cycles, came from Davis. All these trials, phase 1 and 2, and proven the concept of safety in this system. This is the design of our phase 3 trial, which include the control arm as SBRT alone, and the other arm which include, in addition to the SBRT, the use of atezolizumab, which was given as 1,200 milligram every 3 weeks for 8 cycles. And as well, we can see that the SBRT was given as priming in day 1, day 22, then concurrent with the atezolizumab as in day 43, then as consolidation, they given 5 cycles. And the patient included those patients who are early stage non-small cell lung cancer. They are randomized almost 480 patients. This is, as we said, prospective randomized phase 3 trial, and the fashion of trial randomization was 1-to-1 and either to SBRT or as monotherapy or SBRT plus atezolizumab. And the primary endpoint or the primary objective was to compare the overall survival, while the secondary objective was to compare the PFS. They stratify the patient based on the location, size, and performance status, and they did interim analysis, which considered that all the analysis should evaluate the early stopping for futility. And this is important consideration. Based on that, they also considered that the third and the fourth interim analysis will evaluate the early stopping of for efficacy. They plan to do the accrual for 5 years and follow-up for 3 years. The key inclusion criteria, this is important to consider that they included those patients with histologically proven stage 1 to 2A or limited T3N0M0, that means 2B. Non-small cell lung cancer less or equal to 7 centimeter diameter without nodal or distant metastasis. And they allowed also the multifocal tumors. The patient should be medically or surgically inoperable or unwilling to undergo surgical resection. Performance status 0 to 2, and they included 1 or more high-risk features that should be identified in this group of patients. Tumor size 2 centimeters or more, PET CT scan SUVAX 6.2 or more, and moderately or poorly differentiated or undifferentiated histology. So one of these high-risk features should be there. Now, the exclusion criteria, as we usually consider for this patient going for immunotherapy or concurrent radio chemotherapy, that significant cardiovascular disease, NIHA class 2, MI within 3 months prior to randomization, and stable arrhythmias or angina, no left ventricular dysfunction less than 40% ejection fraction. Those patients with severe infection with 4 weeks prior to within 4 weeks prior to enrollment, patients with history of autoimmune disease, they were very cautious. Or other than stable hypothyroidism or controlled type 2 diabetes. So they allowed those with stable hypothyroidism and controlled diabetes. Then also the HIV, hepatitis B and C, they exclude, and also history of idiopathic pulmonary fibrosis, drug-induced pneumonitis or organizing pneumonia. Now the schemata of SBRT, the SBRT starts with cycle 3, that means usually week 7. This is in the experimental arm, and the number of grays, the number of fractions usually ranging from 3 to 8 fractions. The doses of the radiotherapy from 48 gray to 60 grays, and the dose given to the bed ranging from 105 to 151. And tumors were different, either peripheral or central. As we mentioned, that atezo was given in the usual dose, 1200 milligram over 60 minutes every 3 weeks for up to 8 cycles in RNA. The study was started during COVID period, and the first interim analysis was conducted in August 2024, and they evaluated early stopping for futility based on PFS and overall survival comparison. And also they considered a statistical cut-off point of for stopping the treatment, as we can see. 400 eligible participants were included in this interim analysis, and they reported at that time, at the initial interim analysis, 76 patients with progression and 41 patients died. They also notified the sites, the participating site, that to stop the treatment after this interim analysis. Now, the accrual stopped for futility, and this is, which is ethical consideration that they stopped for futility after enrollment to 417 participants after the results which were showed which were consideration for because of the futility issue. Now, as phase 3 trial, we can see that the two arms are well balanced, and we can see that predominant elderly age group, and we have almost 2% of the patient never smoke. This is the result of the futility analysis of the PFS and overall survival. We can see that the study was negative, and the futility, that means no benefit, were met for both PFS and overall survival. So there is no benefit from the addition of atezolizumab to radiotherapy in the early stage. This is the updated PFS, and we can see reproducible results when they evaluated again the benefit. Almost we can see that there is no significant overall survival benefit or PFS for addition of atezolizumab to the SPRT. And this is by type of progression event. They analyzed the local progression event, regional, distant, and death without radiographic progression. So we can see all these parameters at sub-analysis. They confirmed the same concept that there is no benefit for the addition of atezo. And regarding the safety part, we can see that also they reported grade 5 respiratory failure on the atezo arm, which is one patient, less than 1%, and grade 4 hypoxia, MI, VTAC, FFib on the atezo arm, while there is one in grade 4 hyponatremia on this SPRT. Safety-wise, we are so familiar with the immune therapy, and usually in our case, we're considering confounding factors rather than the atezo per se. Now, just to support the negativity or the results of this study, they also, in the discussion, they mentioned that there is similar trial, Keynote 867, which enrolled similar patient population, early stage inoperable decline surgery, non-small cell lung cancer. They randomized in similar way between SPRT plus adjuvant pembro. So this is not only a atezo issue, and given for 17 cycles, and the study was closed early following interim analysis because pembro did not improve EFS or overall survival, and there is increased toxicity. So the trial has its own strength, and this is the first phase 3 trial, this is my belief. And there is excellent PFS and overall survival for the control arm patient compared to historical SPRT, despite enrichment for high-risk tumor features. This is, again, reflecting the proper enrollment factor. Accrual ahead of schedule at time of trial closure despite COVID, which is good, accrual part, and rigorous radiation plan review, and also the central review of the local recurrent events ongoing now. Still, the tissue is available there, and seeded blood samples collected for correlative studies. So they have the chance for further studies because they collected and saved the samples. Now, some of the limitations of this study, that challenges of assessing in-field control and setting of radiation is sometimes difficult to discriminate between increased fibrosis with immunotherapy versus in-field tumor progression. So this is a practical issue, clinical issue. We face it to discriminate between the fibrosis and progression. Also, while the size and the SUV and grade were used to enrich for patients at increased risk of recurrence, the overall event rate on the control arm was low, which may indicate some selection bias. The other limitation that the tumor mutational analysis and PD-L1 expression was unknown. But because there were some plan for corrective workup, but till now the PD-L1 status is unknown. So this is my last slide, and we can say that the key takeaway point from this trial that neoadjuvant, concurrent, and adjuvant atezolizumab does not improve PFS or overall survival with SBRT for early stage inoperable non-small cell lung cancer. SBRT monotherapy remains the standard of care for early stage inoperable non-small cell lung cancer. Thank you very much.
Prof. Ahmed, I'd like to ask the speakers to come to the podium. Prof. Mohsen will be joining us. So the floor is open for discussing very important 4 topics. We can start with Walid.
Thank you for all. It's really excellent talk and review of this important from the perioperative. Is Dr. Mohsen Mukhtar with us? Okay. Anyhow, we'll start with Dr. Hamid. If my question is to Dr. Hamid now, with this 5-year survival for a patient with ALK positive patient, the first line setting. It's always that is magic tricks to start with, and now the first line setting. In the real world, how is those for patients? We know from the clinical trials, even those patients with dose reduction is still doing very well, even for in real world practice, how those dose reduction to go so far in patient, I mean, how to be allowed to go dose reduction in patient with severe toxicity.
So, most of the patients usually they can't tolerate lorlatinib, but still what we are facing most commonly is either CNS effect or hypertriglyceridemia, high lipid profile. So the CNS effect, most of our patients, when we decrease the dose to like from 175, they will tolerate and they will be fine. And usually high cholesterol triglyceride, we try with the anti-lipid first, but if it is not controlled, then we decrease the dose. But most of our patients, usually we decrease from 100 to 75, less likely to be below this. And the interesting, maybe you are facing also, most of our patients who progress on alectinib, when we give them lorlatinib, you can see some patients, they may stay like 3, 4, 5 years on lorlatinib without progression. So I think it makes a big difference in the outcome as compared to second generation ALK inhibitor, especially in BFS and intracranial progression-free survival.
Thank you for the speakers. I have a question for Dr. Hamid and the colleagues here regarding the switching now based on this data, really impressive. And we have patients now just started or they are on alectinib. Are you going to consider switching those patients to the newcomer, lorlatinib? This is the first. The other issue from your practical, experience now with using lorlatinib, based on the data which shows safety data regarding the CNS and psychocognitive part, did you face any difficulties or problems with starting this lorlatinib regarding the CNS toxicity and side effect? And how frequent you do this? Really, when you talk about the lipid profile and the close monitoring issue, sometimes we are hesitant to move to the lorlatinib because of the toxicity part, especially for those patients who are enjoying good quality of life. So do you think that this toxicity part is an issue in starting this drug? Thank you.
Okay. If patient already start on alectinib and responding, I think better to continue on alectinib, and then you may consider lorlatinib as a second line. Most of our patients that we give lorlatinib and they have like CNS effect, when we decrease the dose, most of them usually they become fine and the CNS effect resolved and they can continue the treatment. And I have one patient who was on 175 because of CNS effect, and with the time, my patient changed to 100 and still without CNS effect. The same. I mean, fasting. I mean, lipid profile. I mean, this is something that you will face in the blood, not in as a symptoms from patient. And usually, by giving anti-lipid medication, you can control. Some patient they may control with one medication. Some patient they may need additional 2 medication. But in my practice, I don't face patient that I need to stop lorlatinib because of high cholesterol or triglyceride. I mean, if you are doing like fasting lipid profile, I mean, at the beginning, like every 3 weeks or every 2 weeks, and then later every 6 weeks, I think you can catch if there is an increase in the cholesterol or triglyceride that you can manage without dose reduction.
I think we need to remember that lorlatinib is the best frontline. Even if there is a toxicity, probably we need to work out around this toxicity to make it the first line. Lisa, do you have a question?
Just a comment regarding lorlatinib. Even if you write down the still you can reach an because you mentioned that the therapy is not
And also the PD-L1 status, we don't really know. We don't know the PD-L1 status as well, so we don't really know who are going to benefit or not.
This part that has limitations. So we have to now or the limitation analysis, and because they consider that is very, very early stage patient. So this is the rationale. And the trial was led by mainly radiation oncologist, and even the presenter in the ASCO, the team leader was radiation. But they addressed this as limitation, and this is not the final analysis. They will follow up to 3 years from that termination of the trial. And they kept the samples for further evaluation. So they have the tissue and they have the blood there for further analysis and follow-up.
So, Dr. Walid first.
I think to move to the one of the important that's the neoadjuvant versus the preoperative approach. And I think Prof. Mahsen Mukhtar, that's one of the important when we are talking the tumor boards for those patients resectable to go for the neoadjuvant preoperative approach, and there is to omit the adjuvant setting. What is exactly you are mentioning that's very clear is that only the PCR is the surrogate markers and we can decide on that, or ctDNA, because we didn't adopt yet the ctDNA, circulating DNA, as surrogate markers to see those patients is doing well, no, and no adjuvant therapy. For whom the adjuvant therapy you will omit in the resectable patient.
And thank you very, very much for having me. You can hear me well?
Yes.
Yeah, okay. So thank you, Dr. Walid and Dr. Tariq for this. I always ask myself the same question. Is there a patient you can omit the adjuvant portion for? Till today, I would only omit it for a stage 1B patient when comfortably if they achieve a PCR. Anything beyond that, unless there is toxicity, I will push for the whole perioperative setting. So I will give the full adjuvant portion, including the neoadjuvant.
Prof. Mohsen, so in future, what would be the best piece of evidence if we have to decide regarding whether to give adjuvant or no adjuvant, beside PCR and ctDNA?
I think PCR circulating tumor DNA would be top of the list. And secondly, if these patients, remember, not all types of patients were included, or testing for mutations were included. So
My take is also if there are other mutations, so not just the EGFR and the ALK, if the patient has a RET, MET, HER2, or any of this, these are the patients I might also be omitting the adjuvant portion for, especially if they do not achieve a PCR. But other than that, I think patients with no mutation or a KRAS G12C mutation, I would give the full neoadjuvant as well as the adjuvant portion, even if they achieve a PCR and are beyond stage 1B.
Great. We'll take the last question, then we will have a small, very short case for discussion.
So my question to Dr. Nafisa, I'm sure she knows what I'm going to ask, but I will ask. I mean, now we know ALINA trial comparing alectinib versus chemotherapy. So if you have a patient with a stage 2 or 3A, do you consider chemo followed by alectinib, or you are following the same trial that you give alectinib alone?
I will give chemo followed by definitely by, no doubt. I would not hesitate to give chemotherapy, standard of care, followed by alectinib for 2 years, definitely. I hope you are waiting for this answer.
Can I ask another question in this regard? In terms of patients on the ADORA trial, are a lot of us thinking of omitting the chemo? And why would that not be the same in the ALINA?
I think
Neoadjuvantly and adjuvantly.
I think in the new adjuvant, Prof, again the same. We try to adapt even the ALINA trial. That's the chemotherapy thing, giving the target. Yeah, I think we have a different people, but in general we try to give the best for the patient, giving the chemotherapy, then the target therapy after that as adjuvant.
But if the patient is resectable, would you try to omit the neoadjuvant portion, knowing that these patients are going to benefit from the TKI?
For me, I mean, if it is resectable, I think I will go ahead with the surgery initially. And then maybe stage 1B, because, gray zone, that maybe there is no benefit from chemotherapy. I may not consider chemotherapy. But for a patient like stage 2 or 3A, that we know that maybe chemotherapy gives additional survival advantage, I prefer to give, in my practice, to give chemotherapy followed by osimertinib for 3 years. But if surgery can be done at the beginning, I may consider surgery.
Yeah.
Actually, we are waiting, bro, for 2 trials. Still, we don't have the result using alectinib in the neoadjuvant setting. So till we get that, we will know, shall we start with chemo and then proceed with surgery and then adjuvant, or we can go ahead and just start neoadjuvant targeted therapy and then surgery followed by targeted therapy.
We have 2 questions from the online attendees. The first question to Dr. Ahmed. Stereotactic body radiation therapy has advantage over CyberKnife because we are hearing about SBRT a lot. Please share your experience. Do you have an experience with radiation?
I'm a medical oncologist, not radiation.
Then we can go to the second question. Putting side effects in consideration, what should encourage us to use lorlatinib over alectinib in the first line?
What? As a second line?
First line.
First line, I prefer to use lorlatinib now.
I think the data is very clear.
Yes, the only data that you have BFS at 5 years not reached is with the lorlatinib. So you cannot ignore this.
Conclude this session with quick case, then we can share the experience of the expert group. So a case of stage 2A, right upper lobe lung adenocarcinoma. There was the tumor is about 3 centimeters, and there is 2 or 3 lymph nodes in the hilum. And the PET scan is otherwise negative, MRI is negative. So the biopsy was adenocarcinoma, but the PD-L1 is 90% and MSI is high. So adenocarcinoma lung, MSI high, PD-L1 more than 90%. And patient is fit for resection and has no comorbidities or any preventing factors from going for aggressive therapy. Stage 2A. So I need to know what would be your preferred approach of therapy.
Has he done EGFR and ALK testing?
All negative, NGS negative.
Sorry?
NGS negative, yes.
NGS, okay. Neoadjuvant perioperative for this patient. I think all the perioperative trials could work. Checkmate 770, the keynote, the Aegean, they'd all be perfect for this patient. You only have full overall survival data maturity for the 671. I don't know what's your take.
Okay, node positive, you say?
The Prof. Mahsen, you would, yes, highly positive. So you would prefer to go for the Checkmate 770 approach?
Checkmate 770 or 671 approach, yeah.
Do ABUS or
Hmm?
you do ABUS? I mean bronchoscopy with lymph node biopsy.
Done.
It was positive.
PET negative, yes. So he is truly only high lung.
So sure, it will be neoadjuvant chemoimmunotherapy, as mentioned by Prof.
Neoadjuvant chemo immune.
Yes, chemoimmunotherapy.
And for the MSI high, do you think immunotherapy would be enough as neoadjuvant?
MSI high is still only probably a surrogate marker for metastatic in all the diseases, not for the, I think sometimes we tend to confuse it with, in terms of neoadjuvant or adjuvant setting. I think MSI still is surrogate marker for metastatic disease and use of immunotherapy, not for the neoadjuvant portion, especially in the lung.
Okay. I think this patient, we know that PD-L1 is high, stage 2 with positive lymph nodes. MSI is indicate this is surrogate marker for the response and the biology of the disease. I think that's give us to, we treat this patient as a neoadjuvant or preoperative approach, chemo, immune therapy, looking for cure of these patients, and then from there.
So for one reason, patient had immunotherapy alone as neoadjuvant. I think it was driven, the decision was driven by MSI high. After 3 months, the imaging showed a complete response, even PET scan.
Immune therapy.
Immune therapy. So the question now to the tumor board to go for surgical resection, to continue immuno, to observe.
Sure, surgical resection.
One, you're lucky that he got complete remission with just immunotherapy. This is lucky. And yeah, surgery. Surgery, you have to do the surgery. Again,
are we in the era now to try to omit the surgery, or yet for lung cancer early stage still we try to remove the disease part?
I think it's we're still not omitting the surgery for these patients.
You are treating lung cancer or rectal cancer or you are mixing now?
Thank you so much. It was.
I think that's for the patient. That's good for the patient. MashaAllah, he has now his complete radiological results. At least I think surgery. Then after surgery, we'll decide what will go. How is the plan to maintain the adjuvant? I think, but that's great to know the MSI high. That's more of surrogate for the response. For that, he get to the CR.
Yeah.
I'd like to thank all of you speakers and my colleague moderator, Dr. Walid, for this excellent session. And special thanks to Prof. Mohsen from Cairo, and hope to see you soon, inshallah. Thank you so much.
Thank you. Thank you very much. Assalamu alaikum.
والأمة السيرجرية هو خلاص إن شاء الله.
Testing.
Good morning, everybody. I would like to thank you for being with us. We do have plenty of almost like 400 attendees. Thank you very much for joining. I would like first to thank Dr. Nafisa and Dr. Turki for inviting me. It's my pleasure always to be here. And I would like to congratulate the organizing committee and the scientific committee for selecting the topics. We had a very successful first session. It was very exciting talks about the frontiers. And then we'll start the second session of the Thoracic Day. And the title is A New Frontier and the Challenges in the Treatment of Advanced Non-Small Cell Lung Cancer. It's considered one of the potential prospectively that this types of frontier that may change the landscape, and we'll see this with the topics. And it's my pleasure to introduce our first speaker on the session. He's known to everybody, and he's our dearest and the organizing of the committee as well, Dr. Turki Rifaya, and he will give us a talk about the frontline options for EGFR metastatic non-small cell lung cancer. This is a very exciting topic, and we are very pleased. Thank you very much, Dr. Turki, and the floor is yours.
Assalamu alaikum. Thank you, Dr. Merbat, for the introduction, and it's my pleasure to be with you again in this successful meeting. So I'm gonna discuss the options of therapy for EGFR disease in advanced non-small cell lung cancer. This is my disclosure. Okay, so for a long time, almost now 10 years, the only option of therapy that we use for EGFR positive advanced disease is osimertinib. And this is based on the FLORA trial. And you all remember that the PFS was 18.9 months, and it was astonishing and was a very impressive outcome. However, for the last few years, we start to hear about the intensification, giving more options of therapy to see if we can improve the PFS. For example, addition of chemotherapy to osimertinib, as in the FLORA-2. The other option is using radiation with osimertinib, as in the North Star, or addition of ramucirumab, as in the RAMOS trial, or you basically moving to different agents, lazertinib and amivantamab in Mariposa. So all of these intensification approaches were done to try to see if we can pass the bar of 19 months median progression-free survival. So the FLORA-2 is known to us now. Basically, the common EGFR mutation cases were randomized to osimertinib plus chemo or the standard of care osimertinib. And you can see that the primary endpoint, the PFS, was significantly higher with chemotherapy plus osimertinib from 16.7 months up to 25.5 months. So very impressive improvement in progression-free survival. The other important trial is the Mariposa. Mariposa is a amivantamab lazertinib versus osimertinib. This is a protocol that is omitting the chemotherapy in the first line setting. And again, they included only the common EGFR mutations. And it was a study randomizing osimertinib to amivantamab lazertinib. And again, look at the PFS, very similar outcome. PFS is 16 months in the osimertinib compared to 25.7 months for amivantamab lazertinib. More important, in the ELCC this year, they reported the overall survival for lazertinib amivantamab, and you can see that the curve is separating and kept separating at 42 months, and the proposed difference in survival is about 1 year in favor of lazertinib and amivantamab. We need to discuss the PALOMA-3 because this is so important replacement of the IV amivantamab, subcut amivantamab. And in the PALOMA-3, the assessment of subcut was compared to the IV, and it was found that response rate is the same. However, the duration of response is longer with subcut, and also the rate of VTE, which is a common side effect to amivantamab, was reduced with subcut amivantamab compared to IV. And it was unplanned assessment for overall survival, but it was noticed that there is significant overall survival with subcut amivantamab. Likely, this is related to better compliance with the treatment compared to the IV, which caused interruptions due to adverse events. Also, the convenience. Patient who had subcut amivantamab had a better reported convenience at cycle 1 and at the end of treatment. The incidence of infusion-related reaction is much lower with subcut. 60% with IV compared to 13% with subcut, with only grade 3 toxicity, 0.5% with subcut formulation. I need to also draw your attention to this trial, the RAMOSE trial, ramucirumab plus osimertinib, very similar design. And again, it showed that the combination is better. PFS is 25.8 months. So to put all the trials together, we have osimertinib, we have LAURA-2, and we have Mariposa. In the median PFS table, you notice that there is a clear improvement with the combination approaches compared to osimertinib. And when you look at the response rate, probably response rate is the same, no difference if you give single agent or combination. But the toxicity, the grade 3 toxicity, you notice in the FLORA-2 and in Mariposa, there is about 35 to 40% difference in grade 3 toxicity with the combination approach. So toxicity is a concern with the combination. So the first question come to our mind is, with the combination, do we really improve the progression-free survival and overall survival? I think the answer is yes, especially with the recent survival data from Mariposa. The second question, do we really improve the quality of life? Probably we have more toxicity with the combination. And another important factor is the convenience. Remember, we are now talking about IV formulation, and this could be less issue if we adopt the subcut amivantamab. Who should we go for? Who should we use intensification? To whom should we use intensification? I believe we should offer it to the majority of the patients, especially those with high-risk features, either clinical features or genomic features, and we're going to discuss it in a moment. High-risk features for EGFR positive diseases is well known to be the CNS and the liver metastasis. Also, some biomarkers play a negative prognostic factors, for example, the ctDNA, the exon 21 mutation, and presence of TP53 mutation. If you look at the FLORA-2 and Mariposa, when they assessed the survival, the progression-free survival in those with brain metastases, it was found that the combination approach is better and has a longer progression-free survival. When they assessed the liver metastases, the combination seems to be better with regard to controlling the disease and the metastatic sites. The 3 or more metastatic sites seems to have better outcome with chemotherapy plus osimertinib. And the presence of exon 21 mutation seems to have better outcome. TP53 co-mutation seems to have a better outcome with the combination, and also presence of ctDNA at baseline. So if you have patient with presence of ctDNA positivity at a baseline, they seems to have a better outcome with the combination. If you look at the right-hand side, you will notice that those who had osimertinib, if they have no detectable ctDNA, osimertinib would be enough for them compared to chemo plus osimertinib. So to summarize the first part, we have many approaches for intensification, addition of chemotherapy or addition of dual EGFR MET inhibitors. And the group who benefited more are those with CNS metastasis, those with a baseline ctDNA detectable disease, and those with liver and extensive metastatic sites. However, at the end, all patients, whether you treat them with single agent or combination, they will develop disease progression. And we know from practice that when you have a patient who progresses and has a systemic progression, you need to look at the reason for progression. Is it on-target resistance or off-target resistance? The common on-target resistance is basically any mutation on the receptor itself. For example, C797S mutation, common one. The off-target resistant mutation are any mutation that happens in the receptors around the EGFR receptor. For example, mutation in HER2, or MET mutation, or MET amplification, for example, or fusion. Sometimes RET and ALK would be a reason. And finally, the histological transformation. Previously, we were saying that adenocarcinoma the adenocarcinoma cells that has EGFR mutation can transform into a small cell. But there is now new data to tell that also it can transform into a squamous cell carcinoma. So if we give combination in the first line setting, we are actually reducing the C797S, and we are actually reducing the MET amplification significantly. And this is data from Mariposa, and you can see on the left-hand side that the MET amplification with osimertinib was 14%, and with combination amivantamab lazertinib was only 4.4%. So if you give good intensification in the first line therapy, you are actually reducing the risk of secondary resistance. One of the important and under investigation drugs is the fourth generation TKI. This is a TKI that has been assessed after osimertinib. Very promising outcome from this study, but no phase 3 trials yet. Also, one of the targets of the off-target resistant mutation is actually EGFR MET amplification, MET antibody like amivantamab, or basically targeting the MET mutations with MET TKI like savolitinib, capmatinib, and tivotinib. So there are many trials of osimertinib plus MET TKI. The commonest one is the Savannah trial. Very promising, but there is always concern regarding the definition of the IHC positivity regarding and FISH positivity regarding the MET amplification. Chrysalis 2 trial assessing the amivantamab in those with MET amplification. They defined the MET amplification as a 3+ in more than 25% of the tumor cells, and there is a 60% response rate in MET positive patients with amivantamab. And we know the Mariposa 2 is amivantamab plus chemotherapy in those progressed on osimertinib, and it showed significant progression-free survival. Finally, targeting all comers, basically give a drug that will target any possible mutation. The common that we start to hear about is the ADCs. For example, TROP2 ADC, HER2 ADC, HER3 ADC, MET ADC, very promising drugs that showed benefit. And also trying to target the PD-L1 and VEGF at the same time. So ivonescimab is a very important drug from China that targets the PD-L1 and target PD-1 and VEGF at the same time. And in the Harmony A trial, patients after EGFR therapy were given ivonescimab plus chemo or chemotherapy standard of care. And you see the PFS is significantly in favor of the ibrutinib, as well as clear improvement in overall survival. However, the maturity only reached 52% of the data. ADC is very promising. Datopotamab deruxtecan is a very promising drug, and I know now it's tested plus pembrolizumab in the first line setting. Also, the trastuzumab deruxtecan, patritumab deruxtecan are very promising drugs, and you see the response rate with these drugs is much higher than other drugs in the second line setting. Finally, transformation to a different histology is not low. So keep it in your mind when you practice. If you have a disease that is flaring up, you have to consider biopsy, because there is about 10% of those patients can transform into small cell carcinoma or squamous cell carcinoma. So putting all the data together, you will notice that the response rate in the subsequent lines is increasing down the road, mainly with ADC. The highest response rate was seen. So to conclude my talk, we know that third generation EGFR TKI is improving PFS and overall survival. However, all patients will develop acquired resistance. The resistance mechanism is either on target or off target resistance mutation or histological transformation, and the incidence of resistance mechanism is depending on the regimen, such as osimertinib or osimertinib chemotherapy or amivantamab lazertinib. We have to consider rebiopsy to identify any further actionable alteration or to confirm histological transformation. So far, amivantamab plus chemotherapy is very good second-line option after failure of osimertinib, and we have to really look carefully to the ADCs. I think they are very promising. Results of ongoing phase 3 trials are awaited. Thank you.
Thank you very much, Dr. Turki. It was fantastic talk. We do have a lot of questions, and we'll keep the questions to discussion. Thank you.
Thank you, Dr. Turki. Thank you, Dr. Mervet. And now we'll move to the second talk, or the second session. This talk will be given by Dr. Ahmed Al-Rifai. Dr. Ahmed is a well-known consultant of adult medical oncology at King's College Hospital, Jeddah. Dr. Rifai is also associate professor of oncology at Ain Shams University. Dr. Rifai will talk today about applying clinical trial tropion-02 lung in advanced non-small cell lung cancer as in the first line setting. Dr. Rifai, welcome.
Thank you so much, Dr. Nafisa. I would like to thank the organizing committee for their kind invitation to be with you in such elegant scientific gathering with my dear colleagues. Today my task is to speak about another frontier, which is the antibody drug conjugate in the tropion lung 02. This is my disclosure. I will speak about first introduction on unmet need and how to make the chemotherapy more effective, and then I just give a glimpse about the tropion 01, and then I will go for the main task, which is a tropion 02. So we know here that lung cancer, as all of us we know, is one of the biggest killer. 2 million new cases per year, 1.8 million deaths per year, and we can find that only 30 to 40% with actionable genomic alteration, and still we have 60 to 70 without such driver mutation. Among those patients, we can find that the high expressor PD-1 is about 30% or less, and the intermediate to low expressor constitutes the majority. So almost 50% of non-small cell lung cancer may need chemotherapy as a must in the intermediate and low, or as an option in the high expressor in those with bulky disease, non-smoker, or symptoms. And we know that chemotherapy actually used in the front line, like in the keynote 189 and 407, and we achieve like landmark result of median overall survival about 22 months in the adeno, 17.2 months in the squamous. And we know that this is really related so much to the PD-L1 expression. So we found that the median overall survival dropped from 27.7 months with the high expressor up to 17.2 months with less than 1%. And we can find the response rate also is high in the high expressor, 62% drop to 32% with low expressor. And what about the progression-free survival? The median progression-free survival, for example, in Keynote 189, about 9 months, dropped from 11.1 to 6.2 in the non-expressor. So we can just consider this, for example, 9 months as like a benchmark for patient who is receiving chemotherapy in combination with immunotherapy. So the question, how to make much improvement? Maybe we can add something to the immunotherapy, or we can improve the chemotherapy to improve the chemotherapy added value, maybe to make it more smart. There is always a chance to make something more smart. But what about chemotherapy? Maybe chemotherapy, it will make it antibody drug conjugate, will improve the efficacy of the chemotherapy. And actually, as Dr. Turki mentioned, we have a long list of targets in which we can direct our chemotherapy. We have the HER2 overexpressed cells, HER3, baricitinib, deruxtecan, and we have the TROP2. We have many molecules can just work on it, and we can find that the response rate is ranging from 20 up to 30% with something like MET and also the CCAM. And of course, they tried this medication in the second line, but unfortunately, our contender docetaxel is not very easy to be defeated. As we can see, there is no really improvement in the overall survival. Some non-statistical improvement or numerical improvement with sacituzumab govitecan, but it is not really statistical. So now I will concentrate about the TROP2. TROP2, what is TROP2? It is a trophoblast cell surface antigen. It is a transmembrane glycoprotein overexpressed mainly in solid tumors, but not on the normal tissue. And it controls some sort of the intracellular signaling through multiple pathways, and also can regulate the stem cell marker, and this lead to affection of the proliferation, spread, and the invasion of the cancer cells. And if we just came specifically to non-small cell lung cancer, we find in the adenocarcinoma, the overexpression is about 64%, and we can, of course, debate about the definition of the overexpression. And usually it is related to bad prognostic in a patient with adenocarcinoma in the squamous cell in 75% of the patient, and usually it doesn't impact the survival in the squamous. In the neuroendocrine, it is about 17%, and usually it has, ironically, an improvement in the overall survival in such a patient. And we have many molecules to target this molecule. We have the datopotamab deruxtecan, sacituzumab govitecan, and we have sacituzumab deruxtecan. And we can find some sort of differences related to drug-antibody ratio. It is only 4 with datopotamab and reach up to 7.6 with SG, and also different in the payload. We can find all of them contain topoisomerase inhibitor, but they are different. And also in the linker, the enzymatically cleavable linker with datopotamab deruxtecan, which make it more specific to be released inside as a tumor, and also we have the bystander effect. We have a long list of the tropion lung trials, starting from 01. They tried this medication in the second line, 02 in the first line frontiers, and then with multiple combination with dostarlimab, durvalumab, and also monotherapy in patients with EGFR mutation. And we have a long list of phase 3 trials. Just to give a glimpse about the tropion lung 01, they tried this combination in the second line versus docetaxel, and we can find some sort of mild improvement in the median progression-free survival. Hazard ratio 0.75, median progression-free survival 4.4 months, with only gain of 0.7 months. But the response rate was impressive, reach up to 26%, more than double overall survival. As I mentioned before, there is no improvement in the overall survival. So they try to make more granularity in this to see if it differs by the histology, and actually it was. We can find in the non-squamous hazard ratio for the median progression-free survival 0.63, and there is improvement median progression-free survival from 3.7 to 5.6. So some sort of maybe a little bit acceptable outcome, but for the squamous, it is completely failure. You can find on the contrary, I mean, that Botomab deruxtecan didn't do better than the docetaxel, and in the overall survival, again, we can find some mild improvement in the overall survival in the non-squamous, but totally not in the squamous. So they try to find some sort of marker. We usually try to search for a marker. So what is this marker? Actually, they use the artificial intelligence-driven computational platform in which they not only measuring the amount of the protein, but they measure the intensity of the protein and the location. So if they found the protein is more in the cytoplasm, this denotes that there is much endocytosis activity, and the likelihood that this tumor can respond to the antibody drug conjugate is high. So they just made the concept of normalized membrane ratio. And the normalized membrane ratio positive means that there is a high proportion of cells, more than 75, with low normalized membrane ratio. I mean, less protein on the membrane, more or high percent in the cytoplasm. And if it is less than 75%, so it is called the negative NMR. And they found that patient with positive NMR, they found the overall response improved even more than 26%, reaching up to 32%, while those with NMR negative, it dropped to 16%, and also the median progression-free survival improved from 4.4 to almost 7 months. So apparently, we got some sort of marker for patient with TROP2, so we can use it. And here they just did the combination to check for those with positive and non-squamous, and they achieved even a better progression-free survival, reached to 7.2 in the median progression-free survival, and the response rate even increased to 36% instead of 26%. So maybe with more digging, we can just try to get the maximum benefit of what is supposed to be a smart chemotherapy. And then the next step, of course, to move it to the frontiers or our main subject today, and just to go for the Tropion Lung 02, which is a phase 1b study of the first line datopotamab deruxtecan together with immunotherapy pembro plus or minus platinum chemotherapy to try to mimic the combination of chemotherapy in the Keynote 407 and 189. And here in this phase 1-2 trial is to evaluate both the safety and to try to also to evaluate the efficacy with this combination in the first line. And here we can find this protocol is somehow complicated. They have 6 cohorts, and even in other trials they can find 11 cohorts. So in this 6 cohorts, they include 2 cohort doublet in which they add datopotamab together with pembro, either 4 milligram or 6 milligram datopotamab. And initially they include some patient with more than 1 line, or I mean one previous line, and then after the 30th of June in 2022, they just prohibit the patient who received, and they count mainly on the treatment naive. So this is why we will find in cohort 1 only 2 patients. They exclude the patient who received some sort of previous treatment. And in the 6 milligram, 40 patient, and then from cohort 2, 3, 4, 5, 6, they included the triplet in which there is the datopotamab with pembro and with platinum, either carbo or cisplatin. The primary objective was, of course, safety and tolerability, to see this combination is tolerable or not. And here we can find the patient population. Of course, this is not a randomized clinical trial, so there is a lot of, we cannot compare, for example, doublet with triplet. But here we can find some sort of descriptive numbers. median age was about 60, 65. And I mean, the majority of the patient was, they were non-squamous histology, squamous about 1/4 of the patient. And here in the doublet, for example, 95% of the patient received 6 milligram, which can explain some of the results later on. While in the triplet, only 60% received the higher dose and 40% received only 4 milligram. Coming to the PD-L1 expression, we can find the majority of the patient, about 70 to 75%, they are non-high expressor, and the high expressor only about 10 to 20%. So what about the safety? What is the major safety concern with datopotamab? We can find that the main safety issues here is low-grade stomatitis in about 52%. The grade 3 is about 5%. Nausea is there in 40%, and decreased appetite. Pneumonitis, which usually something risk to be considered if we are offering deroxetican, we can find it is 21%, but grade 1 and grade 2, and grade 3 is only 2%. Of course, the hematological toxicity is more with the triplet. Looking about dose discontinuation and dose reduction, we can find in those patients about from 10 to 20% of the patients they have deroxetican or datopotamab deroxetican dose reduction, and the dose discontinuation in about 1/3 of the population. The serious risk effect was not small and was not very high. It is about 11 to 20%, but there is no reported deaths with those patients, and the maximum median duration of treatment was about 9.7 in doublet and less than 6 months in the triplet. Coming to the efficacy, here we can find what I can claim a clinically significant overall response rate crossing the 50%. We know that in the chemoimmuno, sometimes it ranging from 30% up to 60 something percent in the 407 and 189. So it is not, it is in the neighborhood, it is not very far away. Here, if we look at the median duration of response, it is also impressive. It is not low. It is about 20%, mainly in the doublet. And disease control rate is very impressive. It reached up to 90%. So we have a good response rate, long duration of response in the doublet, and disease control rate also is good. Coming to the medium progression-free survival, did we cross the benchmark of 9 months there? Of course, we cannot compare. This is the trial is only phase 1b, but here we can find the medium progression-free survival is the doublet about 11.2 months, in the triplet much less. Maybe it is related to the dose. That 95 here received 6 milligram. I cannot really, I don't have a clear explanation, but maybe it is dose related, and we will wait, of course, the phase 3 trials. Median overall survival not reached in the doublet and reach here 17.4 in the triplet. And just again to remind you that the median overall survival was 17 in 407, 22 months in 189. Here, if we look at the squamous, non-squamous, we can find in the non-squamous, usually the result is high, especially in the doublet. And the worst, if it is squamous, and if we use the triplet, 6.7, again, it is a descriptive, descriptive of the result. Here, if we look at the medium progression-free survival, again, 11.2 months, overall response 5.4 with the doublet, with the triplet 6.8, overall response rate is 55. And here, when we try to make some sort of fractionation based on the PD-L1, I will only mention in the doublet, we can find overall response rate reach to 100%. And this control rate to 100%, the medium progression-free survival not reached, and the overall survival also still not reached. So maybe we anticipate some sort of improvement. Still, we cannot tell, but just give a hope that this medication can be escalated to phase 3 trials. Again, they use the same NMR biomarker to see what will be the outcome. Could it improve the outcome? Here, if we look at the medium progression-free survival in patients with TROP2 NMR positive, the medium progression-free survival reached to 12 months versus in the negative 8.1 months. Apparently, this biomarker is a valid biomarker. If we look at the doublet, even we can find the median progression-free survival is more impressive, reached to 21 months, hazard ratio 0.5, overall response rate reach up to 70%. So apparently there is a potential by using this, for example, in patient with NMR positive, maybe in patient with non-squamous, we can find some sort of good result. So in conclusion, we can find in the tropion lung 02, the final analysis from the tropion lung 02 anti-tumor response with the first line datopotamab, pembro, platinum, just see some sort of response regardless the PD-L1 expression. Response rate is above 50. Comparison between the doublet and the triplet, of course, is not possible because they are not randomized with different baseline criteria. No unexpected safety signals. Retrospective, the TROP2 NMR analysis suggested a potential trend toward improved BFS, overall survival in patient with TROP2 positive patient, and this medication should be taken to phase 3, and actually this took place in the tropion 07 and the tropion 08, in which they divide the patient in patient with high expressor. They offer the datopotamab with pembro versus pembro, I mean the standard of care. And in patient with non-high expressor, they offer the patient with the combination versus also the protocols like the 189 like protocol. And by this, I end my presentation. Thank you.
Thank you. Thank you, Dr. Ahmed, for the excellent presentation. Now it is the time to move to the next speaker and the third lecturers.
It's my pleasure.
Yeah, go ahead.
It's my pleasure to introduce our next speaker, Dr. Marwan Al-Higili. He is known for everybody, Associate Professor of Medical Oncology and the Chair of Medical Departments on King Abdulaziz City University Hospital in Jeddah. Dr. Marwan, he will give us a talk about lazertinib versus osimertinib in first-line EGFR mutated advanced non-small cell lung cancer, randomized double-blind Mariposa study. So we'll switch the gear again, and Dr. Marwan, he will give us the talk. Dr. Marwan, thank you very much for joining, and the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. Mirvat, for the kind introduction, and thank the organizing committee actually for the invitation. And also special thanks to Dr. Turki and Dr. Ahmed for laying the ground for my presentation. As Dr. Mirvat said, this is an exploratory analysis from the Mariposa, which is looking into the third arm compared to the standard arm, which is lazertinib versus osimertinib in EGFR mutant non-small cell lung cancer. Now, the title say it's a phase 3 study, but for this special exploratory analysis, it will not be considered a phase 3, and I will explain to you in a minute why. Okay. So the objective will be some background about EGFR mutant non-small cell cancer, the trial design, which is actually the most interesting part of this talk. We'll talk about some of the efficacy data, the safety data, and then we'll come back to the clinical implication of the study. Now, as we all know that EGFR mutant over the last, I would say, 20 years, we've been just dealing with this kind of tumor. First started in the East, where they have about 30 to 50% of the population, mainly female, having this mutation. In the West, it was about 10 to 15%. And the question, how much of this percentage is actually here in our population? And I think the data that was reported in multiple small studies, it shows that maybe we are around 28 to 35% of our lung cancer population have EGFR mutated. In my practice, somehow I have more, but I don't know what's the reason. There are two predominant mutations, the exon 19 and exon 21, L858R. And as we all know, there are like the different generation of anti-EGFR came actually to overcome all the mutation, especially the T790 mutation. Now, the current treatment landscape, as laid out by Dr. Turki, is very clear. The first generation TKI, erlotinib and gefitinib, between 2009 and 2014. And then the resistant developed, which is the T790 or the MET application or small cell transformation or any other mutation. And then we have the osimertinib, and I think few years that we've been using osimertinib as the first line treatment for most of our patients. It's considered a third generation TKI. And of course, it has a better superiority when it comes to efficacy as well as to CNS penetration. Lazertinib itself is another third generation TKI similar to osimertinib. It has a CNS penetration, and it was evaluated actually in the Mariposa study as laid out by Dr. Turki. Now, going back, I'm just going to ask one question. Does anyone know what Mariposa means? Okay. Well, it means butterfly, and I'm sure there is a nerdy geek who decided to name it that way for something related to the way that the molecule looks like, but I don't know the reason. In this study, the main outcome was actually the progression-free survival by independent radiological review. The second endpoint was overall survival, response rate, duration of response, and also, of course, penetration to the CNS and safety. Most of the study was actually designed with stratification based on EGFR mutation, based on Asian versus non-Asian and ECOG performance status, and the analysis method as laid out by Dr. Turki. However, the third arm, which is the lazertinib arm, was compared to osimertinib in a descriptive analysis way. It was not compared in terms of checking efficacy or non-inferiority or superiority. So it's mainly all what I'm going to say after this is actually a descriptive findings in the study. So that's why, even though we call it a randomized phase 3, for this specific arm analysis is not considered something that we can go and base our practice upon. Eligibility was very clear as laid out by Dr. Turki. I just want to make sure that controlled CNS disease was included. Leptomeningeal disease was excluded from the study. Now, we also, as the patient characteristics, and I'm just going to focus on the two arms. And as you see, female, Asian, performance status, type of mutation, brain metastasis, it was all similar in both arms when we compare osimertinib to lazertinib. The first finding is actually progression-free survival. Just looking at the curve, you will know that they are on top of each other. However, if you look at the numbers, numerically, there is a slight difference of about 2 months when it comes to PFS. Hazard ratio is almost 1.98, and of course, the p-value would not be significant in this case. If you look at the high-risk subgroups, whether brain metastasis, detectable ctDNA, or TP53 co-mutation. If you look, again, the curves look similar, but slight advantage for lazertinib over osimertinib numerically. However, none of those numerical improvement have any p-significant value. If you look at the time to symptoms progression, well, the median was reached in the osimertinib, and it's 29, and in the lazertinib, it was not reached, and we can see that there is a difference in the end of the tail, actually, between lazertinib and osimertinib. If we look into the overall survival, which is not mature, not estimatable, we don't have a median yet, but the hazard ratio is 1, so most likely they are equal in that regard. If you look at the overall response rate, there is no difference. It's 83 to 85% overall response rate. Complete response, 4% for each, and the rest actually, they are similar. The duration of response, again, 16.8 months for almost both of them. The safety profile, grade 3 safety profile, nothing high. I think the drug is almost the same as osimertinib if it comes to safety. Grade 1 and 2, There are some variation in diarrhea and rash, but overall, they look similar in grade 1 and 2. So there is no red flag or any just something that we notice when it gives us just it's more toxic than the other. They look like identical actually. And this is just to summarize the safety profile, the diarrhea, the stomatitis, the paronychia, all of those were similar, but grade 1 and 2 were high. We see that with the osimertinib, and I think we're going to see the same with the lazertinib. In terms of QT prolongation, it looks like lazertinib has a better safety data when it comes to QT prolongation. As you see, 17 patients had QT prolongation, but 0.7% in the lazertinib arm. If you look at the left ventricular ejection fraction worsening, numerically speaking, it's not that different, but again, lazertinib has an advantage. So if we see there are some advantage flags that will shown in the efficacy outcome, and now when it comes to safety, only when it comes to cardiac safety, there was some advantage for lazertinib. So clinical implication, I think since earlier I said, and I mentioned, this was not designed to show efficacy, to show superiority or non-inferiority. This was designed as just a descriptive finding. Yes, both drugs they have the similar efficacy. There is just minimal advantage in terms of safety and certain safety profile like cardiac in favor of lazertinib. But however, the drugs, both of them look the same. And again, as I said, there is no difference in efficacy, but as Dr. Turki has presented the Mariposa, it looks like the advantage is to the combination arm of amivantamab and lazertinib. The question will continue to be there, whether lazertinib can be replacing osimertinib, or the opposite, whether osimertinib can be replacing lazertinib in the combination. And I don't think that's something we're going to find in the future because no one is going to plan this study. However, I think it's good to know that those drugs look similar in terms of profile. And with that, I thank you.
Thank you very much, Dr. Marwan. Excellent book. We'll keep the questions at the end, inshallah.
Thank you. So we'll move to the last lecture of today, last but not the least. Glad to introduce our colleague, Dr. Abdurrahman Al-Gabban. Dr. Abdurrahman is a senior medical oncologist at King Faisal Hospital and Research Center, Riyadh. Dr. Al-Gabban will talk about comparison between AK-112 versus pembrolizumab in the first-line setting, non-small cell lung cancer. This is a primary analysis of Harmony 2. Dr. Gabban, please.
See my slides. Can I have my slides, please? Assalamu alaikum. Thank you very much for the organizing committee for inviting me to present this. It's an honor to be among peers and group. This is Dr. Abdulrahman Rabban. I apologize about earlier. This was some technical difficulties. I'm going to be present the phase 3 study of ivonescimab. I would just be calling it AK112 versus pembrolizumab in the first treatment of PD-L1 positive non-small cell lung cancer. The trial name was Harmony 2. So just to lay some background, anti-PD-L1 monotherapy or in combination with chemotherapy has been established as a standard first-line treatment of PD-L1 positive advanced non-small cell lung cancer without any driver gene alteration. AK112 is a novel bispecific antibody against PD-1 and vascular endothelial growth factor, and has shown promising clinical efficacy and safety as a frontline therapy in patients with PD-L1 positive advanced non-small cell lung cancer in the phase 2 study of AK112. AK112 is a humanized IgG1 bispecific antibody that targets PD-1 and vascular endothelial growth factor. Beside the well-known anti-angiogenic effects of the anti-VEGF agents, also there's some data showing that it can modulate the tumor immunomicroenvironment, and this results in efficacy of the PD-1 inhibitors. This is a schematic diagram that was presented by the AK112 developers, and just showing the unique bispecific antibody of this drug. It has an anti-PD-1 efficacy, anti-PD-1 targets, as well as anti-VEGF targets as well. And this is in theory and to enhance the microenvironment of the immunomicroenvironment around the tumor cells, and this enhances the efficacy of the immune system. So Harmony 2 is a phase 3 study. The patient included stage 3B incurable or advanced non-small cell lung cancer. No prior systemic therapy. These patients are treatment naive. They should have no driver mutation specifically for EGFR and ALK, from a status of 0 and 1, and PD-1 has to be at least 1%. They were stratified by histology, by clinical stage, and TPS score 50 or less than 50. They were randomized 1-to-1 to the treatment arm versus pembrolizumab being the standard of care. The primary endpoint was mainly PFS, and secondary endpoint was overall survival, and exploratory analysis was quality of life, and this was presented in World Lung 2024. Baseline characteristics. Nothing to highlight apart that all patients have been similar. The PD-L1 was across the group equal. Just would like to highlight they did include some liver metastasis patient and brain metastasis, but the most majority were had no involvement of these sites. So the primary endpoint, the study met actually its primary endpoint, and the was PFS in favor of the intervention arm versus pembrolizumab, 11.14 versus 5.8 with significant hazard ratio. And this was true across all the subgroups. The PD-L1 with more than 50%, you can see the clear separation 11.1 versus 8. We can look as well in the smaller group, more than 1% less than 50. Similarly in the squamous histology and the non-squamous histology. So this was truly positive across all groups. And the overall population was all positive. Again, I just want to highlight here that the regardless of the histology, it was positive, and regardless of the TPS score, as long as positive, it was efficacious. Again, highlighting the liver metastasis, the brain metastasis, and metastatic sites. They were not the large population of this trial, but they were included, and it was positive across all. Again, the overall response rate was higher with the intervention arm versus the pembrolizumab arm, and the disease control rate was higher. Side effects, as expected, the side effects profile were more or less similar, but there was some specific side effects that were more seen with the intervention arm, and this is most likely related to the anti-VEGF mechanism of action. So you would see there was a lot of proteinuria, a lot of hypertension, and the grade 3 was slightly higher in the intervention arm compared to other, but nothing was significant enough to lead to discontinuation or death. And just here highlighting the proteinuria was generally higher, and hypertension was higher as expected with anti-VEGF inhibitors. What about the immune side effects profile? Were similar across, But only thing that again to highlight here is mainly the anti-VEGF side effects. Quality of life, both treatments did show no statistically significant difference in terms of quality of life, slightly numerical in favor of the intervention arm, but nothing significant statistically. So in conclusion, first lines AK12 significantly improved PFS in patients with advanced and small cell lung cancer with PD-L1 more than 1% in mainly Chinese patients. This is one of the limitations of this trial, that this was done specifically only in China, and OS was not mature at this time. The BFS benefit was seen across all subgroups with the major ones, and I think this trial warrants further validation of the diverse cohorts, so we can have another option for these patients, chemo-free. I think that would be interesting for our patient. As highlighted before, there is a significant number of our patients who have no driver mutation, and to have a chemo-free treatment, I think is important for them. With that, I conclude. Thank you.
Thank you very much, Dr. Abdurrahman. That was excellent overview. I would like to invite our speakers for the discussion, please. Please come to you. So it was a great session for all the speakers. Thank you very much for clarifying. And I think as the title of the session regarding the new frontier and the challenges, because it's like that we are adding to the medications like it was presented, or even new comers like TROP2 or the AK 112. This is considered something that we are modifying, and we are looking at the total unmet needs on our practice. So I will start. We do have a lot of questions from our attendees. Thank you very much for submitting. I will start first with the great talk with Dr. Turki. It was the front lines regarding EGFR. We do have now, after exploring EGFR many years, it's almost now like 21 years since the introduction of EGFR in 2004, we start to have the co-mutations and also the other mutations that we are stratifying common mutation and uncommon, like EGFR exon 20. So the question is that we are using osimertinib as an upfront, as a standard of care, but now we are exploring the co-mutations like P53 and MET amplification as well. So in your practice, if you do have a patient coming to you, we do have now the combinations, single agent, which one we have to go. And in the meantime, also, do you are using ctDNA in your practice, or we should go for it? Thank you.
Thank you, Dr. Merbat. So I think the combination approach now is a fact that we have to deal with. And personally, I believe it should be the standard of care, first line therapy combination. If I have the lazertinib available, I would really vote for amivantamab lazertinib as a first line. But my practice now is chemotherapy plus osimertinib, definitely for selected patient who will tolerate the toxicity. I will look carefully really to the TP53 co-mutations, because we know that for a long time, and there's cumulative evidence that this is associated with poor prognosis. So really better to hit them with the best options you have. This is all subgroup analysis, but again, from practice, TP53 is not good. Chemotherapy plus osimertinib. And I have two patients on this approach. Unfortunately, one of them could not tolerate 2 cycles of chemo with severe bone marrow toxicity. So we required to basically drop the carbo and keep patient on pemetrexed and osimertinib.
Perfect. And Dr. Marwan, he also presented the lazertinib and the osimertinib. So we didn't see that much comparable to both medications in terms of the data. So the point is that we do have the amivantamab plus lazertinib, and we do also have the osimertinib. Do you think that if in the case of we don't have lazertinib on our it will be soon. But I mean, if you don't have, we didn't see much comparable to those post medications. So what do you think?
It's your point. You want us to consider osimertinib, amivantamab?
We cannot, we know that we have to respect the clinical trials, but when we have two medications, we see the similarity, and we can see that as Dr. Marwan, and we want his comments as well, that it looks like topping each other, and we didn't see much difference. So this means that you will add cost and toxicity, and we also still have the osimertinib as the golden standard. So what do you think?
Very, very difficult, but I will probably stick to the evidence. I will be very hesitant to add osimertinib to amivantamab. This is one thing, and we cannot get rid of, by the way, osimertinib is staying with us because we have evidence in the adjuvant setting and the locally advanced and in the metastatic. So I think this drug will stay with us, especially I hear now in the WCLC, they would release the survival data of FLORA-2.
Yeah.
So if there's a FLORA-2 survival benefit, then it's still a very, very good option. So I think lazertinib should be there for amivantamab.
So Marwan, your comment, please.
Well, I think,
Yeah.
I mean, I'm sure there is a background story to the lazertinib, and I think the story, most likely, this drug has been there in the shelves for some time and at Janssen or a smaller company. And they didn't do the study to show superiority or anything because they lost the time, because we all remember that all the studies for first-line anti-TKIs came either against older treatment like chemotherapy or first-generation TKI. So that's how they won, and they became part of the standard of care. But I'm assuming lazertinib just came late, and now to catch up, they combine it with amivantamab. I think if they design it with osimertinib, maybe it would have been better. But anyway, they combine it with lazertinib. But to replace osimertinib for lazertinib, I don't think I'm going to do it. In my mind, I think it's going to be the same, but I cannot do it to the patient. I cannot.
So as you pointed that we, and Dr. Turki as well, we do have the LAURA and also we do have the ADAURA. So for patient with EGFR and patient progressed after either LAURA or ADAURA, because LAURA it's forever, and for the ADAURA for 3 years. So if you do have a patient after a year or 2 years, and the EGFR coming again with a common mutation, which type you may go, as we have a cross resistance and it will be the same. Okay, so it's for you, Dr. Marwan, if you want.
No, I'm sorry. I got cut for a minute. You mean the combination of
no
what?
Problem. So,
yeah.
I mean, on the subsequent therapy, especially that we do have the ADAURA and we have LAURA. And so can we do have now lazertinib and amivantamab. Which type of treatment you may go? You may re-challenge again, especially for a patient 1 or 2 years, they are free of disease, or you will go for the combination with lazertinib and amivantamab.
I think after 2 years, even in the study, it was not included. It sounds like a good idea to go for the combination, but to tell you, in my practice for now, I'm just gonna go with amivantamab for failure. Okay.
Yes, I have a question if you allow me to clarify. So, Dr. Ahmed, ADC is a chemotherapy. We are considering it as chemotherapy. So, in the trial, they added ADC to immunotherapy and chemotherapy. So, for regimen, let us assume that the patient tolerates this regimen very well. And this that did not affect the quality of life of the patient. What will be your subsequent therapy? How are we going to sequence the treatment after giving ADC, immunotherapy, chemotherapy in the first line setting in a patient who don't have mutation? Let us assume that, and their PD-L1 is below 50, let us say.
So again, this is merely like chemotherapy. For example, if the patient with adenocarcinoma and I start to use something like datopotamab deruxtecan. Patient later on progressed, maybe I will just go for docetaxel. The problem will be something like squamous cell carcinoma. Actually, it doesn't work very well in patients with squamous cell carcinoma. So if I started this treatment, and I will not start it in upfront, but usually I will go with subsequent chemotherapy. I will start with subsequent chemotherapy, mostly taxanes. But actually, for the time being, the evidence which we have up till now, it is promising, but it is not really so much compelling to start to use it up till now. The result in the progression-free survival and, of course, in the overall survival doesn't up till now dictate to use this medication. Maybe in the second line, even in the second line, again, you must put some sort of prerequisites to use it in certain group of patients. For example, the non-squamous patient with positive NMR. So those patients who can get benefit. But so far, I don't see, a chance for changing the, treatment paradigm. Maybe after the result of the phase 3 clinical trials, this will be more clear for us.
So how do you see Dr. Ahmed that the TROP2? Because as you mentioned that we do have many trials before, and it doesn't show that the superiority or the studies was not dramatic, like when we put the driver mutations comparable or the PDL1, it was a changing practice from the second day. However, in the TROP2, we do have cetuximab, govitecan, and also we do have the data. Now, the point is we see there is some efficacy, but it's not like changing your practice on the second day. How do you see that? Especially that you pointed that the TROP2, it's 60% almost on the adeno and even higher on the squamous. We know that there is some efficacy, but still we don't know exactly how to use or what is the patient profile.
Actually, the data is so much crude up till now. Still, you cannot draw a conclusion from what we have up till now. But I think we must do some sort of fine tuning. Now we have many factors there. The pathology is a factor can affect. The NMR is a factor can affect. The doublet versus triplet is a factor can affect. So still up till now, many factors can affect the outcome. So I think up till now, we cannot draw a conclusion. We must wait the phase 3 trial, and we must have some sort of prerequisites to guarantee the best outcome of this smart. If it is smart, the drug should be smart, and our action also should be smart. So now we got some data, but we need to just like put it together to make the best, recipe out of this. We have a potential, but still up till now, no real solid result which we can use it in practice the second day in the clinic.
Perfect. We do have a very good question by the attendees to you, Dr. Abdurrahman, regarding the AK112. So it's a promising one, and as you pointed, this is a Chinese one. And the combination between the VEGF and PD-1, it was brought before by the Avastin plus Atezo. However, it was not on the landscape of practice to be the standard of care based on that was a quadri, and also we didn't see comparable. So my question regarding it, first is the design of the study, because it was a single agent comparable to Pempro as a single agent. We are not using Pempro as a single agent from PDL1 from 1 to 49, and I think it should be the study design only confined with the patient with 50%, more than 50% based on 042. 024. And the other point that we can see there is efficacy on this part. So what you can see, what you comment regarding the design of the study and also the outcome regarding it.
I think the study has few critiques. The first one, the standard of outcome. To me, perhaps this is maybe because it's very specific to the Chinese population. But if you look at the numbers of median survival, it looks like a bit shorter than those we meet in standard in the West, or at least are more global. So I'm not sure if the immunogeographic or hereditary part plays a role in the immune response. And we know while cancers perhaps share the same name, but they share this different outcome among different population. So I think maybe that plays a role. The 1 to 49 immunotherapy as a single agent is an acceptable practice, but perhaps superior with the combination chemotherapy. We know our patient lung cancer, majority of them may be frail and may not be chemo tolerable. So I think still it's a fair option for these. I think the beauty of the regimen is just at least to monitor the safety and the fact it's chemo-free. And this is one of the highlights I like in lung cancer, that we're moving away from chemotherapy as much as we can to improve the quality of life and the survival.
Yeah, I
I've
agree.
seen
It's a promising.
Yeah.
And we can see even for patient with 1 to 49, we can see the difference regarding the PFS and the response rate. And it's in this combination, it works nicely. And it was a good message, but the issue that we were considering that the control arm should not be under treated. So the exam arm was superior even on comparable to overall survival and the PFS. So it's a very promising.
I comment, Dr. Sarbat. I think the ivanaslizumab, number one, we need generalizability. We need to have data, international data, to tell that this Chinese drug is better than the standard treatment. Number two, as you mentioned, in the 1 to 49, they are comparing it with kind of inferior option.
Yes.
Pembro. So I think that there is an ongoing trial, I think Harmony 7. They are looking at the 50% and above Pembro plus versus ivanaslizumab global. So this study, if it is positive, it will replace the Pembro. And I think maybe this is the only place where we can put it. And definitely the other place they need to test is the patient who progressed on EGFR. So ivanaslizumab plus chemo is very good in that setting, but we need to test it generalized in a global manner.
Absolutely. Yeah, please.
Thank you. It's really good discussion. And my questions to Dr. Turki and Marwan. Now, I think still for that is good for our patients. We have osimertinib, chemotherapy, FLAURA2, and just we are waiting from WCLC for overall survival. And seems it's positive. And then we have lazertinib, MIRBOSA, and nivolumab. I think that's good options for our patients to have those options in the first line setting. Any patients, how to be tailoring those patients who have only for osimertinib? Still those patients, you can treat those patients with only single agent osimertinib in the first line setting? Or I think we have to go, as we now started the combination therapy, chemo, osimertinib, or lazertinib, nivolumab, and seems all those becomes available, and is available in the market.
I agree that we will have many options, but now we will have option of non-chemo option, nivolumab, lazertinib. Especially when we have the subcut, it will be much easier on patients to have oral tablet plus injection at home. So that's one important thing. Osimertinib is there, and I don't see a difference when it comes to the combination, which one you will choose, unless there is a difference in survival between both. But osimertinib should be there all the time, because many patients are having comorbidities, cannot tolerate the combination, and you will still need the osimertinib as a baseline drug in your pharmacy for those who cannot tolerate the combination.
Yeah. In the regard, I think Dr. Merfatchi mentioned about those can be gives osimertinib or the nivolumab. I think with lack of the evidence, that's I think outside of the clinical trials we cannot do that. I mean, combinations, especially if there is lazertinib is available. But I think to stick to the evidence, that's the lazertinib, nivolumab, or chemotherapy, osimertinib.
Yes, I
Also,
agree
I think if I'm okay to add, patient counseling now, we have options. And I think patient has to know about the three options.
Exactly.
Which one is chemo-free, which one is not, and the side effects profile. I mean, Mariposa, yes, the one of the beauty of Mariposa is the longer you're on it, the less side effects you will have. While in Flora 2, because you're receiving chemotherapy, your side effects are very cyclic. So that's one of the difference. But again, VTE risk is very high with the combination with AMI. So there is a lot of history and a lot of counseling with patient which one they prefer. And I think the subcutaneous formulation will really solve one of the major problems of coming very frequently, and it will go back to almost like urine oozing, where they can receive at home and then you can see them back in 2 to 3 months with the next scan, which is much convenient. And possibly maybe even us as well. Like we looked at Paloma 3 with the subcutaneous formulation was much better than IV, and likely because of compliance.
Do you think, Dr. Abdurrahman, that we should implement the ctDNA for the patient evaluation regarding the response? Of course, we are assessing the radiological response based on every 3 months for the patient. But I believe that ctDNA now it's considered one of the tools for the patient assessment, but still we are lacking this part in our region. It's still also not validated all over the world and still in many of the centers. But in putting this together, if you are using a kind of medications and you wanted to assess the response, should be as well as the washing time of the ctDNA. It seems that if it is less than 60 days, it looks like based on the osimertinib data, that it may show that those patients, they are responding. Do you think that you will vote for implementing this technique as well?
I do. I think they add a lot of value, but they add information, sometimes maybe limited implication yet, but they have been now coming into the adjuvant setting and the metastatic settings. And I think it would help your clinical judgment and timing the scans. For those who clear the ctDNA very quickly, you may need to space your scans. You don't have to see them very soon. That can sometimes a good relief for the clinic and for the patient themselves. Also, the liquid biopsy does have a role in progression, and sometimes you can detect some new alteration or sometimes a resistant alteration and save you the need of biopsy if they progress. There need to be a lot of validation, but there are many trials that require tissue biopsy. They also use liquid biopsy to help and try and find a concordance. And this way you can perhaps even save them the need for a needle biopsy. This is very convenient.
Yes, I agree totally. In the lung cancer consensus, which is we held parallel with the WCLC, they are recommending that to do a tissue biopsy plus the liquid biopsy, either on the adjuvant setting or even on static patient, just for confirmation and not skipping any. So what is the challenges regarding our areas? Why we are not still on this part? We are rapid on the medications. However, the investigations were a little bit lacking on this part. So as King Faisal, why guys, you are not starting this part?
I think to find a commercial one that is being standardized across many countries or many bodies, I think that's one of the main reasons. If you notice, each study, they have their own baseline or their own benchmark liquid biopsy. So even the way they detect the ctDNA is different in the adjuvant rather than the metastatic, because they have to use the same tumor DNA and try to platform it so they can detect it quicker and easier with more specificity and more sensitivity. So I think there are a lot of challenges in the technology of the liquid biopsy, and I think it's not yet being unified. It's not just about being detected or not, because you need the best one to detect even at a lower number where you can have established really positivity or not. So I think that's one of the main challenges.
Yes.
Can you comment, please? I think ctDNA is not yet validated, although I heard from one of the pathologists doing this, and now in the breast cancer, one of the studies just presented in ASCO, I think, INNOVA trial, they are downgrading or minimizing the treatment or upgrading the treatment upon the ctDNA.
Yes.
So I think it can be used here as well in lung cancer, especially when you start with 3 medication. and you are planning to have maintenance treatment. So at least the ctDNA might help you to minimize or decrease the burden of the medication. Especially, we know our patients are most of the time elderly, most of them having multiple comorbidities. I think the role here is very important, not just in follow-up, but also in de-escalate the treatment
Yes, agreed with that.
for in the maintenance setting. So we can have like induction and then maintenance. Maybe when you are planning to go for the maintenance, it is a time to do ctDNA.
Yeah, I voted to what you're saying, Dr. Nafisa, concurrent totally. I think it also with the data was updated data was 816 regarding patient with adjuvant, patient with PCR and negative ctDNA. They're not need to go for adjuvant as well. And as you mentioned, we do have the colon cancer data as well, and also the lung cancer regarding the ctDNA for even the IMpower 010. So the patient with positive ctDNA, they will benefit from the immune therapy. However, the patient was, the negative one didn't show benefit from the immune therapy. However, the positive one with ctDNA, those are the patient who can supposed to be candid. I believe that we need to tailor it to give de-escalate or giving the conventional based on the biologics, not only on the morphological.
Yeah, I think so. Yeah, thank you.
Do we have any questions from the floor? And also from the online. I think we are reaching to the end of the session. I would like to thank all the speakers virtually, Dr. Ahmed Al-Rifai, Dr. Marwan Higeli for excellent talk, and thank you for Dr. Turki and Dr. Abdurrahman for excellent talk and review as well and discussion. Thank you for your questions, and it's my pleasure to end this session. Thank you again.
Thank you. Thank you.
Okay, so it's my pleasure to introduce, to go for the next the Satellite Symposium, BMS Satellite Symposium, and it's my pleasure to introduce our chair of the Satellite Symposium, Dr. Ahmed Al-Lahibi. Dr. Ahmed Al-Lahibi, he is our dearest friend and one of the eminent speakers and the chairman of the thoracic oncology in Saudi Arabia. Dr. Ahmed Al-Lahibi, he will chair the BMS Satellite Symposium. Thank you very much, Dr. Al-Lahibi, for joining us, and the floor is yours.
Assalamu alaikum all, and good afternoon, I would say. Thank you so much, Dr. Mirvat, for the kind words. You rendered me speechless, actually, to come up with a good compliment to those words that you just mentioned. I'm really privileged and honored to share this session led by BMS, for which I extend my gratitude and appreciation for them to put me as a chairman, for an eminent speaker that is Dr. Turki Paya. Dr. Turki Paya is a very well-known and iconic medical oncologist, I would say, in the field of thoracic and GI malignancies. He is a medical oncologist who practices as a consultant in National Guard Hospital in Riyadh. He's been in the field for quite some time now, and he's going to teach us an update about the CheckMate 9LA and the role of the dual immunochemotherapy. As we heard from the previous sessions, that the chemotherapy is not the best option for most of our patients, unfortunately, especially if they have lung cancer. Hence, the CheckMate 9LA's idea is to only wrap up the immune system or prime it up for immunotherapy with only 2 cycles of chemotherapy alone. Just to mention one comment I failed to mention in the previous session because I was quite intrigued in the discussion part is the osimertinib and lazertinib. I would agree with Dr. Marwan, agree with Dr. Mirvat, and agree with Dr. Kifaya that lazertinib should be the only thing to be given at amivantamab. However, osimertinib is there to stay. As mentioned by Dr. Kifaya, it's in the neoadjuvant setting, it's in the adjuvant setting, it is in the metastatic setting, and now we have a phase 2 study coming on with the combination of osimertinib plus amivantamab. on the hopes that DVT is going to be eliminated. So yeah, osimertinib is here to stay. Without any further ado, the floor is all yours, Dr. Turki.
Dr. Ahmed, it was a pleasure to see you online. I hope to see you physically, inshallah soon. So I'd like to thank PMS for sponsoring this satellite symposium. The title is Dive into the 6-year follow-up of the Checkmate 9LA data in context. So this is my disclosure slide. So we know for quite some time now that the options in the first line setting in those who do not harbor any mutation are increasing. And we have now options of therapy based on PD-L1 expression, also based on histology, and also based on patient preference and also patient tolerance. For example, when you look at the PD-L1 more than 50%, you have 3 options of single-agent immunotherapy. And when there is PD-L1 less than 50%, then the options are immunotherapy plus chemotherapy, or immuno plus immuno, dual immunotherapy, or immunotherapy, dual checkpoint inhibitors plus short course of chemotherapy. So if you look at the data of the PD-L1 expression and their efficacy on the treatment outcome using first-line pembrolizumab plus chemotherapy, you will notice that with the looking at the overall survival, you will notice that the benefit is become less and less with the lower PD-L1 expression. And the most benefit was driven mainly by those who have PD-L1 50% or more. The same thing for progression-free survival. From the Keynote 189, you will also notice that good benefit in PD-L1 more than 50%, the less benefit in those less expressors, and almost very, very low benefit in PD-L1 less than 1%. A pooled analysis was presented at 5 years of the 2 trials, the Keynote 189 and Keynote 407, looking at the efficacy of the immunotherapy pembro plus chemo in patient less than 1%. And again, at 5 years, very minimal benefit seen regarding the progression-free survival and overall survival. There is a numerical difference, but if you look at the curves and with regard to overall survival, there is they are almost reaching each other with regard to benefit. And this is a real-world study assessing the PD-L1 expression efficacy on the treatment outcome. They looked at the first-line immunotherapy plus chemo in patient less than 1% compared to those with PD-L1 expression of 50% or more. So on the left-hand side is the survival of the squamous histology. And again, there is a benefit clearly if PD-L1 is more than 50% compared to those less than 1%. And on the right-hand side is the survival of the squamous, of the non-squamous histology, and clear benefit if patient had 50% PD-L1 expression compared to less than 1%. So there is no doubt that the lower PD-L1 is associated with lower outcome. When we combine the anti-CTLA-4 plus PD-1 or PD-L1 inhibitors, you are actually inhibiting the interaction between the CTLA-4 and the B7, and this will induce de novo anti-tumor activity. And using PD-L1 or PD-1 inhibitors, restoring the anti-tumor T cell activation, and giving chemotherapy with these 2 drugs is not only killing or increase the tumor killing, but also induce the immunogenic cell death and also improve the T cell priming. So there are many indirect benefits of addition of chemotherapy. This is a meta-analysis in a Cochrane analysis looking at the level of PD-L1 expression and its efficacy on the treatment outcome. So there is no doubt that PD-L1 more than 50% is better to be treated with immunotherapy compared to chemo. But those with a PD-L1 less than 1% chemotherapy wouldn't be of benefit alone. So you have to give them or to add some agents to help those patients. And this is the publication of the 6-year follow-up of the Checkmate 9LA. It was published in the ISMO Open Journal in 2025. And just to remind ourselves with the design of the Checkmate 9LA, it was a very well designed study looking at patients with stage 4 or recurrent disease without sensitizing EGFR or ALK mutations. And they were randomized into a short course of chemotherapy, 2 cycles, plus nivolumab every 3 weeks and ipilimumab every 6 weeks, or chemotherapy for 4 cycles. They stratified patients based on PD-L1, which is excellent thing they did. So stratification was less than 1% or more than 1% PD-L1 expression. And also they stratified patients based on the histology, either sequem or non-sequem histology. So this is the overall survival at 6 years, which is 72 months. You notice here that the overall survival 16% at 6 years with the Checkmate 9LA protocol compared to 10% with the chemotherapy alone. So at 6 years, still we see a significant difference, and the curves are maintained to be separated. They assessed the outcome based on the tumor expression. So the upper 2 curves are those with the PD-L1 less than 1% and more than 1%. Look at the PD-L1 expression less than 1%. There is a clear benefit with regard to survival at 6 years. And so nivo-ipi chemotherapy, the 20% overall survival rate compared to only 7% with chemotherapy. And it was not as impressive when they looked at PD-L1 more than 1%. So the difference is only 5% benefit with nivo-ipi plus chemotherapy. Looking at the tumor histology, the efficacy of tumor histology based on the survival, squamous histology seems to drive a lot of significant benefit, 5% in the chemo arm compared to 14% with the nivo-ipi plus chemo. And it was not seen with the non-squamous histology. The benefit was not impressive. They assessed the survival based on histology and PD-L1. So what is the benefit if a patient has squam and PD-L1 less than 1%? It seems that this is the best group who benefited. The hazard ratio is 0.52, very low. And the benefit is improved from 6% with chemo up to 20% with nivo-ipi plus chemo. This is the duration of response by histology. Squamous histology seems to have a significant improvement in the median duration of response and in the 6-year duration of response percentage. Okay, so finally, moving to the STK11 and KEAP1. We know these are emerging mutations that are associated with worse outcome, and we have to look carefully to the STK11 and KEAP1 mutations because they are not uncommon in lung cancer. If you see in this graph, they come after KRAS mutation. So KEAP1 mutation is about 17%. STK11 about 11%, up to close to 12%. So they are common to see them in lung cancer. The problem with STK11 is that the patient who carry STK11 mutation, they have cold tumor microenvironment. It means that the tumor itself cannot trigger the immune system. And usually the infiltration of CD8 T cell is low, and also the patient with STK11 mutation, they have lower PD-L1 expression. Look at the PD-L1 expression from many trials on the left-hand side. The blue bar is indicating the level of PD-L1 expression. And you see that the level of PD-L1 expression is low in the mutated cases compared to the wild type. On the right-hand side, this is the T cell infiltration. Patient with STK11 mutation, they have very low CD8 infiltration in the tumor. The same thing for KEAP1. KEAP1 is associated with lower T cell infiltration and associated with lower response to single agent immunotherapy. So in the keynote, in the Checkmate 9LA, they looked at the groups based on the mutation versus wild type in the KRAS and STK11 and TP53, and you see that in the KRAS mutation there is a significant benefit, the same for STK11 compared to the wild type, and the same for the TP53. I think the Triton trial is an important phase 3b trial to really give us the clear answer regarding the efficacy of the dual immunotherapy plus chemo in the STK11 or KEAP1 or KRAS mutations. This is a trial that is randomizing patients with one of these mutations into chemotherapy plus dual immunotherapy, or pembrolizumab plus chemotherapy, the standard of care, and the results are awaited. So to adopt the proper adoption of the treatment algorithm nowadays is really, first of all, to exclude any oncogenic addiction, and then to look for the PD-L1 expression. And if you have 50% or more, you have the 3 options of single agent immunotherapy. But remember, try to avoid it in never smokers because they seem to not have a good response. Avoid it in those with STK11 and KEAP1, and questionable question mark about the gender efficacy and gender response to single agent immunotherapy. For those with PD-L1 less than 1%, less than 49%, we have many options of immunotherapy plus chemo, or dual immuno plus chemo, or immuno alone. However, in PD-L1 negative patients, I believe we really should be very careful to select the best treatment. So nivolumab, ipilimumab plus short-course chemotherapy, or tremelimumab plus durvalumab plus chemotherapy need to be really considered for those with less than 1% PD-L1, those with brain metastases, those who are harboring STK11 and KEAP1, and those with squamous histology. With that, I conclude. Thank you.
Assalamu alaikum. Thank you so much, Dr. Turkify. That's an excellent presentation as always. And you touched base on very hot topics that we always keep in mind before we decide upon the best chemotherapy approach. I got a couple of comments. Then I've got a couple of questions as well for you, Dr. Turkify, just for the sake of time. So the first comment that you touched base on, and I totally agree with you 100%, is the STK11 KEAP1, which is basically due to the hyperprogression phenomenon that can be seen should a single agent immunotherapy being given, or single agent immunotherapy given with chemotherapy in patients with STK11 KEAP1. And I would add to that list the KRAS. As you mentioned, the cold tumor microenvironment has been seen quite significantly with STK11 KEAP1 because of the decreased T effector T cells and the memory T cells as well. There's a lot of studies that looked at that. But the KRAS as well, or the RAS mutation, it can lead to T cell exhaustion. So this presence of the absence of T cell being present in the tumor microenvironment will lead definitely to the tumor hyperprogression phenomenon. It has been looked at in exploratory analysis, as we've been shown us basically in the Poseidon study, as well as in Checkmate 9LA, and now we have the Triton. We're all looking forward to the Triton study, just to assess basically if that's going to be the case. There's going to be another gene coming in, the LK11B. Basically, it's just a byproduct of STK11, but another genetic mutation, the KT2MC, which has been shown that it decreases the efficacy of immunotherapy and the Asian study. So that is something else to be thought of. So question for you, Dr. Turki. Let's say that you're going to have a clinic tomorrow, and you are going to see a patient with metastatic non-small cell lung cancer, adenocarcinoma. How would you approach that? What are the main key points that you have to look at, the histology, genetics, and the patient status to decide upon Checkmate 9LA or single-agent immunotherapy or single-agent immunochemotherapy?
Thank you, Dr. Ahmed. So the first thing you would look for is basically the genetic alterations. I think this is the first thing you need to look for. And then you need to look for the PD-L1 expression, and also patient comorbidities and patient also preferred. So if there is no alterations and the PD-L1 is low, less than 50%, then the options, you have many options here. However, if the PD-L1 is less than 1%, especially if the patient has a squam or had brain metastasis, then I would really consider the dual IO plus short course chemotherapy. And I'm really looking at the STK11, KEAP1, and KRAS. If any patient has any of these mutations, I will definitely consider the dual immunotherapy because they are the best group who benefited from the dual IO. At least dual IO plus chemo, but if I cannot give chemo, then at least dual IO therapy. Although it's not Saudi FDA dual IO, but those patients will benefit the most.
Absolutely, I totally agree with you. Dr. Kifayat, remind me again, I think you had a patient with dual IO and she's been doing, or he's been doing so far so well that you had presented about a year ago. What's your experience with the dual IO versus dual IO chemo?
I have dual IO. The more experience actually, Dr. Ahmed, is with dual IO plus chemo. So the Checkmate 9LA actually had a few cases on this approach.
Yes.
So at least I have two patients now. They are off therapy. They completed the 2 years of dual IO, and one of them is actually coming to the clinic every now and then. Complete PET scan, negative PET scan. She's doing well. She's always complaining about thyroid therapy, hypothyroidism. So she is doing very well. The other patient is now still on maintenance, dual IO. So I think I have good experience with.
That's excellent. How about the side effect profile, Dr. Turkis? What do you think?
Toxicity?
Yeah.
Initially, I will tell you the truth, I was so hesitant because the dual IO seems to have higher immune-related adverse events. But for the few patients that I treated, it was a common. So definitely the thyroid side effects, some skin rash changes, dermatitis, but no significant or life-threatening really adverse events. So I think it's very manageable. Especially that
I think you summarized the whole algorithm. Yeah, I think you summarized the whole algorithm of metastatic non-small cell lung cancer and such an excellent and elegant presentation. One last question for you. I don't see any questions from the audience here and online at least, but one last question for you. Have you noticed any kind of correlation between the overall survival benefit, response rates, and the early emergence of side effect of immunotherapy? For instance, hypothyroidism, or like some kind of skin rashes related to autoimmune diseases. Did you notice that the sooner that the side effect would occur, the better the responses would be?
I noticed that with the single agent immunotherapy, the patients who develop earlier and more severe adverse events, immune-related adverse events, they seem to have a better disease control. Even when you stop the drug, they had a longer duration of response. So in practice, I noticed that. There's a question.
Absolutely.
Nafisa would like to ask a question.
Thank you, Dr. Turki. Very excellent presentation. Dr. Al-Hebi, if you allow me, I have one question. Actually, it is comment. I don't know your experience with CKT mutation and KIP mutation. They are very challenging, very difficult patient to treat, and you have to catch the patient as early, start your treatment as early. The problem that our patient usually, as I always mentioning, they are having poor performance status. They are not fit for the combo. At the same time, they will not benefit from dual immune only because the microenvironment, as we mentioned, is not ready for dual immune only. So you need the immunogenic effect. You need the release of the antigen, which that will cannot happen without having chemotherapy upfront. So you need the release of the antigen, then you will activate the action of the immunotherapy. So how do you do that? The elderly patient, poor performance, sometimes you have a delay getting the result of PD-L1, and you have challenging cases you have to treat. I lost two of my patients. I was not able to catch them and to start treatment. And then when I received the NGS test, I found they were having those two mutations. Yes. So I have one patient with the same mutation, and he is doing very well on dual immunotherapy as maintenance. But the maximum result that we can get is a stable disease. So I need your comment about this. Are you seeing the same thing or? you are seeing something different?
I totally agree. Those who carry KRAS mutation, keep on, probably they have more poor prognosis. They are more sick. And at that point, you have to tailor the treatment based on patient performance and ability to tolerate treatment. So if patient is having really borderline performance, I would probably definitely wait for the NGS, but I will go for single agent chemotherapy until I get the NGS result. It's negative and patient is having no other mutations, then single agent immunotherapy plus chemo. So not to go aggressive until I see improvement in performance. I think tailoring the treatment at this group of patients is so important. The experience with the 9LA protocol for me were seen effective in those who are actually fit to start with. So yeah. So one patient had brain metastasis, and I chose to go for the 9LA because he had brain mets, and he did very well. The other patient was basically STK11 mutation, young, she's 45 or 48. So I think the key here is to choose your patient for the best option.
I think that's an excellent question, Dr. Nafisa. It's a brilliant one, actually. I share the same experience with Dr. Tukifaya. I have a couple of patients, like 3 patients with RAS, and one of them had a STK11, and they've done brilliantly with the checkmate candidate. The dual immunotherapy still has a role in those mutations, but as you mentioned, the antigen is not as quickly released. But I think that's their best bet, because if we had chosen to give them a single agent immunotherapy, even in the context of high PD-L1 as in the KEAP1 mutation, then basically they would just succumb to have a progression phenomenon, unfortunately. But I would agree with the overall approach. So I don't have any further questions to you, Dr. Kifaya. If there's any questions from the floor? Okay.
No.
Well, with that, I would conclude this session, and I'd like to extend my thanks again to our dear colleagues in BMS, and I would extend my thanks and gratitude and appreciation to Dr. Kifaya for conducting such an excellent and elegant presentation as usual. Inshallah, I'll be there in person next time, just to see you all and say hi to you. And thank you all. Assalamu alaikum.
So thank you so much.
Okay. Break. When we'll be back, I think
So we will be back to the last session at 1:10. So we'll have a break for lunch. 1:50. 1:50, yes. So 1:50 to have the last session, inshallah.
السلام عليكم ورحمة الله. أسعد الله أوقاتكم بكل خير. We would like to thank you all for joining this session. This will be our third and last session for today. Please make sure to fill the attendance link to make sure that you get your CMEs if you are from the eligible targeted professional healthcare professionals. Also would like to remind you that we have an app right now and you can join our meetings or our virtual meetings, upcoming virtual meetings by clicking that app and downloading it in your mobile. And you will find also the details of any meetings that we will do in the future in that app. Thank you very much, and we wish you a pleasant, informative, educational activity. Thank you. We will be starting in 5 minutes. شكرا جزيلا. بارك الله.
Assalamu alaikum. Good afternoon, everyone. I will come back from the lunch and prior break. So we're gonna finish our meeting today with the session number 6. The title of the session is Changing Treatment Landscape in Lung Cancer. I'll be honored to moderate this session along with my colleague, Dr. Ahmed Al-Rifai. He will join us online soon. So I would like to start the first lecture in this session. The title is SBRT for oligoprogression, will be presented by Dr. Salam Al-Shihri, well-known radiation oncologist, specialized in stereotactic radiation therapy, and he is a consultant and section head of radiation therapy at King Abdulaziz Medical City, National Guard, Riyadh. Dr. Salam.
Thank you, Dr. Fahia. Assalamu alaikum wa rahmatullah. I would like to thank the organizing committee, Dr. Nafisa, for organizing this conference annually to catch up with updates in topics related to lung cancer management. So today I will talk about the stereotactic body radiotherapy in oligoprogressive disease. So first of all, we would like to go over the terminology regarding oligometastatic disease. If you see, there are several papers have been published over a decade. The first one was an editorial about the oligometastasis published by Hillman in 1889 and published in 1995. Another one talking about and ramping up all the definitions regarding terminology, oligometastasis disease, oligo progressive disease, oligo-persistent disease, and what is the different types between them, either synchronous or metachronous. For oligometastatic disease, initially, it's a limited metastasis disease. So you don't see it as diffuse, but you see it less than 5 metastatic sites. There is no universal definition about the oligometastases, but there is a big guidelines and a bold definition about it, which is less than 5 metastatic sites. In the European Society, they define it as less than 5 metastatic sites, but 2 organs. Oligometastasis can be presented as synchronous or metachronous. Synchronous when the patient presented with oligometastasis, metachronous when the patient developed oligometastasis while on treatment. This is a nice summary of the definitions I just mentioned about the definition of oligometastatic disease subcategories. The incidence of oligometastasis is well known to be high in non-small cell lung cancer, reaching about 50% based on literatures. The first trial has been addressed, the role of stereotactic radiotherapy was published in 2017. And it shows that if you add safer stereotactic radiotherapy on maintenance treatment or chemotherapy systemic treatment, you reach a significant progressive-free survival, 3.5 months, in comparison to 9.7 months with significant p-value. This was followed by another trial, which is a Gomez trial. Find it. So this Gomez trial, it was a landmark trial on oligometastatic disease. And if you see the enrollment of patients with advanced stage of non-small cell lung cancer, but they have 1 to 3 metastatic sites. So patients on this trial was enrolled, even if they have brain metastasis, they treat the brain metastases, and then they roll it through.
1 second, just the mic is not, the mic. For him? For the online, they hear it?
Yeah. So if you see these patients in Gomez trial, they have 1 to 3 metastatic sites. If the patient have a brain metastasis, they treat the brain metastasis and then they enroll these patients. And then they randomize these patients to either standard of care treatment or adding stereotactic radiotherapy. And if you can see, all patients that were non-BT, but ALK arrangement was allowed. And it shows a significant outcome for these patients regarding progressive free survival. And this trial was, again, about triple of outcome, 5 months instead of 11 months. And since then, we had the belief that adding stereotactic radiotherapy to metastatic non-small cell lung cancer of 1 to 3 metastases is superior to standard of care alone. This was followed by a phase 3 randomized trial, the SYNDAS trial, and it shows again adding stereotactic body therapy to 5 metastatic sites for non-small cell lung cancer was beneficial and positive in terms of progression-free survival and overall survival with significant p-value. So the previous 2 trials was phase 2, and this one was phase 3 trial. A landmark trial was published in 2020, which is the SABRE COMET trial. And it shows that adding stereotactic body radiotherapy to standard of care palliative radiotherapy while the patient on systemic treatment, it actually reflected an increasing of overall survival with significant local control reaching of more than 70%. And it proved that stereotactic body radiotherapy was a safe treatment as a local treatment. Interesting outcome of piling all these trials was published last year, which called a tool they used with using restricted mean survival time, not only overall survival, but to restrict the mean survival to stereotactic radiotherapy, and they piled all these trials since 2017 till 2024, and they found that there is an increase of survival and the efficacy of adding stereotactic body radiotherapy on maintenance treatment is superior to maintenance therapy alone. And you can see, I highlighted in green about the phase 3 trials, and it shows an increase of survival in SYNDAS about 7.9 months, and in COMET about 12.6 months. So now we have a solid evidence of adding stereotactic body radiotherapy in oligometastatic disease. And we know that oligometastasis, as we mentioned, either synchronous or metachronous. Now we have a solid evidence of increase of survival of adding stereotactic body radiotherapy. Now we are exploring the oligoprogressive disease. This is the a diagram. It shows and summarizes what is the definition for oligoprogressive disease. The oligoprogressive disease, that means the patient have metastatic disease. When you add systemic treatment, you end up with few lesions responding to treatment, but less than 5 months are progressing while the patient on treatment. The oligopersistent disease, the oligometastatic category is induced. So the patient presented initially with diffuse metastases, not oligomets, but when you add systemic treatment, you induced the stage of diffuse metastasis to oligometastases. And when you treat the patient, you end up with less than 5 metastatic sites, which they are oligopersistent disease. There are several papers on this. The first one was the STOP trial, it's a Canadian trial. We're starting recruiting in 2016 and published this year in January 2025. And it shows there is no difference in on overall survival in the patient population. We need to highlight that patient population was 3 primary sites, the lung 44%, GU 23%, and the breast 13%. And they, in the comments of the trial, they said that the compliance to protocol was suboptimal. The second trial is the RADIANT trial. Again, oligoprogressive, the same definition, less than 5 metastatic sites. And the patient population, they didn't include lung, only GI, GU, and breast. Most of the patients was GI. And the 1 year overall survival is 75%. And the comments of this trial and the conclusion that adding SBRT delayed the change in systemic therapy about 50% of the patients. The RADIANT trial. And it was published in 2024. An interesting trial published 2024 in The Lancet, adding stereotactic body radiotherapy to a patient population, lung and breast, again with the same definition, less than 5 metastatic sites. And they compared the outcome between lung and breast. And they found that the outcome for the lung patient was superior in comparison with no difference in the patient population of having primary breast. And you can see here the progression-free survival is 2.2 months in comparison to 10 months when you ask stereotactic radiotherapy in the lung patients, but not the breast patient. And they comment on the breast that there is no difference between oligo, either adding SBRT and progression-free survival or overall survival. This is an oligoprogressive disease, again, paper published in 2023, and it shows adding SBRT in oligoprogressive disease only lung patients. And they found that 2 years progression-free survival reached 56%, and the 2 years overall survival 14%, and the 2 years time to next treatment when you shift systemic treatment is about 9 months. And they found that the 0 to 2 lesions have a superior outcome when you compare it to 3 or more lesions. What we conclude from all these trials that if you see usually lung cancer has the lead on stereotactic radiotherapy in the category for metastatic disease. And actually the main and the big bulk trials, Gomez trial and Comet trial, all of them published on a lung population in comparison to other primary sites. And here we have the evidence when you mix the patient population to different primary sites, the outcome and the influence and the results was reduced in comparison when you have it to a lung primary alone. This is a paper I always like to refer to, which is the oligometastatic and non-small cell lung cancer patient selection. If you see here, the metachronous patients, they have the superior outcome when you compare it to synchronous. So when the patient developed oligometastatic while on systemic treatment, have a superior outcome when the patient presented with oligometastatic disease. And in synchronous patients, when they presented with oligomets, if they have a lymph node metastases, they have inferior outcome when you compare to the patient who doesn't have it. As you see here, when N is 0, and they have superior outcome in comparison up to 5 years, they reach about 30%. When you compare it to patients who have a positive node and metastases, the maximum 5 years they can reach, it's about 13%. So patient selection is a determinant factor for stereotactic radiotherapy. So the take-home message that we have a solid evidence now on adding stereotactic radiotherapy on oligometastatic disease. So SBRT now is considered a standard of care on a patient on systemic treatment when they fulfill the definition of oligometastatic disease and lung cancer. And then we go deep, and we know that metachronous patients, they do better than a synchronous metastatic population. Now the role is evolving for oligoprogressive disease. As we mentioned, either patient presented with diffuse mets and you induced it with chemotherapy systemic treatment, either chemo or immunotherapy to oligometastases, and then they differ, either going oligoresistant disease or oligoprogressive disease. And here is the evidence is evolving regarding stereotactic radiotherapy. Patient factors have a great influence on outcome, of course. We know clearly in oligometastatic disease, the patient can have skeletal mets different than having visceral mets. Skeletal metastases, they do better, they reach 5 years overall survival in comparison to patients who have visceral metastases. And thank you so much.
Thank you, Dr. Salem. Now just we'll go for the second speaker today. I'm very delighted and honored to present Dr. Abdurrahman Al-Shehri. Dr. Abdurrahman Al-Shehri is a consultant medical oncologist at Johns Hopkins Aramco Healthcare and the director of the Oncology Fellowship Program. Dr. Abdurrahman, the mic is yours, please.
Thank you so much, Dr. Ahmed. Assalamu alaikum wa rahmatullah. Masā al-khair jamī'an. Thank you so much for the nice invitation We are always looking forward to this meeting to update ourselves and to learn more about the new updates in many oncology domain. Of course, today we are going to talk about lung cancer. Lung cancer had been and also in the future is leading the therapeutic development in precision oncology and personalized oncology, and it's actually the prototype of many other cancer in this field. So I was assigned to talk about a very specific topic, which is efficacy of zipalertinib in non-small cell lung cancer patients with EGFR exon 20 insertion mutations who received prior platinum-based chemotherapy with or without imivantamab. So a little background on EGFR exon 20 insertion. As we all know, targeted treatment really started with introduction of ALK or anti-ALK treatment when treating ALK-positive breast cancer with crizotinib. Then, of course, we have the common mutation with EGFR, and then it's really exploded after that. And every time we are trying to memorize one drug, we'll have a new one. So really, now we have a lot of things to memorize, and sometimes it's very difficult even to pronounce. So as we all know, EGFR treatment have been basically treating common classical EGFR mutation. We have many options that works very well as a first-line treatment. We always have this difficulty treating the uncommon mutation. And one of them, especially that we know from long time, is EGFR exon 20 insertion mutation. This particular mutation, there was no treatment for it other than giving the patient chemotherapy. Giving the patient chemotherapy is really, the prognosis is not that good. It's as good as, or even as worse than the non-mutant mutant lung cancer. And more recently, we have imivantamab that was introduced as a targeted treatment for EGFR exon 20. It was introduced as a monotherapy and subsequent line of treatment, or with combination with chemotherapy as a first line. Imivantamab is an antibody. We all know the antibody that cannot be given as oral treatment. It's not that easy drug to be used as all other antibody, especially with treatment reaction. We have many monoclonal antibody that we are really very careful when we give it to the patient. We know them for the last 20 or 30 years, starting from rituximab and going with the other. So it's really similar to it in terms of reaction, the imivantamab. And the other thing is the side effects other than reaction is also not easy, including rash, diarrhea, and other side effects. So this is really what bring the need to have an oral treatment, different biology, tyrosine kinase inhibitor, okay, to be similar really to other EGFR mutation, that patient can stay on the treatment for a long time. So zipalertinib was developed with this idea in mind. It's a novel EGFR tyrosine kinase inhibitor that showed promising clinical activity and manageable safety in phase 1 and 2 study. I think the early clinical preliminary data was presented in ESMO 2024 with dose finding and preliminary efficacy. So this actually was the next phase trial, which is a phase 2B trial. It's called Resilient-1. And basically it's a one-arm clinical trial that used zipalertinib, okay, for all the patients in the study. So there was no control arm. So this is the study design. Basically, the patient who is enrolled in this trial are patients with advanced non-small cell lung cancer with documented EGFR exon 20 insertion, and also CNS metastasis was allowed. to be in the study. So again, this is a phase 2b study. So all the patients received the drug of the study, which is zipalertinib. Dose finding was in the previous trials. So this is a fixed dose, 200 milligram PO, so oral BID. And basically, the area of interest was two cohort of patients, two group of patients who had platinum-based chemotherapy without any target treatment. And the other group that they tried to see what's the difference is group who received platinum plus other targeted treatment for exon 20 insertion, which is imivantamab. Okay, so most of the patients either received chemotherapy or chemotherapy plus imivantamab. There is other targeted exon 20 treatment, but it's really minority of patients. Most of the patients is this two big group. The primary endpoint, they were looking for objective response rate and duration of response. This is really what they were looking into. There was no comparison with anything or looking for any final data. They just want to confirm the efficacy of this drug. So the secondary endpoint, of course, was progression-free survival and overall survival and other things. The main group for all the patients, or what we're calling them primary efficacy population, there were about 176, and all of them received the drug of interest as a subsequent line of treatment. So this trial is for subsequent line of treatment. It's not for first line. So if you look for baseline demographics, most of the patients age-wise were in mid-60s in all groups. And there was a good number of patients with CNS brain metastasis. As we know, CNS and brain metastasis is one of the common area of failure of the treatment and lung cancer with driver mutation. So there was almost 30% of the patient in the platinum-based group with CNS metastasis, and also about 40% in the other groups who received targeted treatment. Again, this is a subsequent line of treatment. This trial is for later line of treatment. So all the patients were heavily pre-treated. The group that received platinum only without any targeted treatment, there was multiple lines of treatment, but the median line of treatment was one. Patients who received prior targeted treatment, the median line of treatment were 2 lines of treatment, okay? There is a good number of patients who received prior treatment with anti-PD-L1 immunotherapy, almost half of the patients in all groups. Again, the main 2 groups is a group that received imivantamab, and the other group received no target treatment. So the patients who received imivantamab was 83% of the patients. The other targeted treatment were really the minority of the patients, but there is many other treatment that was received. Mobocertinib is a targeted treatment, also Avastin, osimertinib, and other targeted treatment, but in a very small number of patients. CNS metastases were allowed, so patients who were with CNS metastases either with stable disease or with treated disease, but again, it's minority of patients who received radiation therapy, so there was a good number of patients who had brain metastases in this study with no radiation treatment that was given to them. Okay, so here the result, we go to the efficacy of zipalertinib, confirmed objective response rate for the primary efficacy population. So all the patients who received the drug was 35%. So this is a good percentage because this is a subsequent line of treatment. So you're talking about patients who received prior treatment, and they still 35% with objective response rate. So this is in all group. For the patient who received chemotherapy with no targeted treatment, the objective response rate actually was higher, 40%. The patient with prior amivantamab or other exon 20 insertion had less treatment response, about 24%. So again, all population, the efficacy was 35%. Patient with chemotherapy, no target treatment was 40%. Patients who received target treatment before was 24%. This is objective response rate and subsequent line of treatment, zipalertinib. Median duration of response was 8.8 months in all group. So if you look into a patient who received target treatment, which is really the area of interest here, the amivantamab was about 84% of the patient who had targeted treatment. And if we look to confirmed objective response rate, we will find 30%. So actually, it's similar to the patient who had received no prior targeted treatment. So 30% for patients who received zipalertinib after amivantamab. So zipalertinib is working after amivantamab with chemotherapy. Patients who received other prior targeted treatment, the response rate was only 14%. So here you look into difference between these two numbers. And I think they did the study really because finding this two number, it seemed to be that zipalertinib is working after chemotherapy. Okay, no problem. Is working after chemotherapy plus amivantamab, no problem. So it can be used as subsequent line of treatment. There is no much cross-resistance between amivantamab, which is a monoclonal antibody and tyrosine kinase inhibitor. But it seemed to be that when the patient received tyrosine kinase inhibitor other than zipalertinib and then receive another tyrosine kinase inhibitor, the response rate will go down. This is, it seemed to be, it makes sense. But again, this is a good conclusion that you can use this tyrosine kinase inhibitor after monoclonal antibody amivantamab. Or at least this is one of the options of the patient. Median duration of response, it's 14 months for patients who receive amivantamab in the first line. So this is also a good result and maintained response for this tyrosine kinase inhibitor after patient who was heavily pretreated with other drugs. When we look into brain metastasis in particular, which is also an area of interest for any lung cancer with driver mutation, common site of failure, we find a good response. So there is a very, very clear intracranial activity, 35% objective response rate for zipalertinib with a patient with brain metastasis. 31%, I'm sorry. 35 is for the whole population, 31% for patients with brain metastasis. So it's similar to the patient with to the primary group that have no brain metastasis. So this is a good result. Median duration of response was 8 months. If you look to response, you'll find a good response in big group of patients. That's also very encouraging for this drug which is used in subsequent line of treatment. If you look into progression-free survival for the whole group was 9.4 months. Patient who received no target treatment before was 9.5 months. Patient who received amivantamab or other target treatment was 7.3 months. So again, there is a good progression-free survival data in this line of treatment with zipalertinib. If you look into overall survival, very raw data that is just measured in one group of patients. In 1 year, 73% of the patients were alive, and those 73, they did not, they received only platinum in first line, and then they received zipalertinib. 69 for patients who received more targeted treatment for all group, and 59 for patients who received a prior targeted treatment. So again, this is the data like it's present in this trial for patients who received zipalertinib as subsequent line of treatment. Adverse events and safety were really very interesting point to discuss and to look at in this clinical trial, because basically the other targeted treatment, amivantamab and other, they are toxic, and really there is a need for less toxic drug. The discontinuation rate from this treatment was about 8%. There is 2 deaths that they say that's related, which is pneumonitis and hypoxia in a very heavy pre-treated patient, 1 patient with 6 prior lines and 1 patient with 4 prior lines of treatment. But the main side effect was rash, 30%. This is really very low percentage when we compare it to other tyrosine kinase inhibitor. So I would say this is not really as bad as other tyrosine kinase inhibitor. The area was about 21%, anemia 19%. So again, this is an okay safety profile actually, if you compare it with other drugs. There is a 12 patients, about 4.9%, who had treatment-related pneumonitis. So this is also was mentioned as a side effect of zipalertinib. So in conclusion, efficacy of zipalertinib demonstrate clinically meaningful efficacy in patients with EGFR exon 20 mutant non-small cell lung cancer who received prior platinum-based chemotherapy, including those who also received prior amivantamab. Very important point. I think this is really the highlight of the trial. Patients who received amivantamab as a first line, which is maybe the standard of care now for exon 20, can receive zipalertinib as a second line. It doesn't seem to be there is a lot of cross-resistance in here. In regard to safety, I'm seeing that based on the trial, I haven't used it, but based on the trial, I'm seeing really a less toxic drug compared to other tyrosine kinase inhibitor, and also compared to amivantamab. So in summary, this findings support zipalertinib as a potential treatment option for patients with EGFR exon 20 mutant non-small cell lung cancer that progressed on platinum-based chemotherapy, either including amivantamab or just only chemotherapy. But this is a phase 2 trial, and there is also now Resilient 3, which is a phase 3 study in first-line patients, so as upfront line treatment. So that's it, and thank you so much.
Thank you, Dr. Abdurrahman, for this excellent abstract presentation and discussion. We will move to the third speaker, Dr. Mervat Mahrouz, our colleague from Prince Sultan Military Medical City in Riyadh. She will discuss an important abstract, which I believe is a practice-changing in the extensive stage small cell lung cancer. She will discuss the phase 3 M40, which is lorlatinib plus atezolizumab as a maintenance therapy in extensive stage small cell lung cancer.
Thank you very much, Dr. Turki, for introducing me, and I would like to thank you again and Dr. Nafisa for holding this meeting and congratulations for keeping this meeting on annual basis with us. So the task was given to me is lorlatinib plus atezolizumab as a first-line maintenance treatment in patients. So we'll switch the gear from non-small cell to a small cell, and we know that this group of patients, they even 15%, and majority of the patients presented with extensive stage. However, still percentage of patients, about 20%, they may coming with localized. However, the topic today, it's mainly about the extensive stage. Can we move? Yeah. Okay. So before we go to the main topic, we just have the top three misses regarding small cell, which is it's difficult to obtain tumor tissue from the small cell patients, one size fits all homogeneous approach. And the small cell are not ideal candidate for clinical trial. So this is mainly that most of what we are finding regarding the small cell patient today, and also lacking of clinical trial positive for this patient. And when we look at this slide, you can see that how it's starting from 1950 until now. We can see that how it's very slow. It's almost taking for us about 10 to 20 years to obtain an efficacy regimen for this group of patients. And we are talking now about the extensive stage. So starting initial was the cyclophosphamide, it was in 1969, followed by the CAV, which is the cyclophosphamide, adriamycin, vincristine, and then topotecan, and then etoposide platinum, which is mainly still the standard of care for this patient as a chemotherapy backbone, and PCI is still a controversial issue, and down to 2010, which is the thoracic consolidation therapy for these patients. When we look at starting at 2018 was the era of the immune therapy, of course, we had a glimpse, which is the IMpower 133 and the Caspian study using IO. It was not a breakthrough, but it was a glimpse, and it was breaking the ceiling of that frozen types of tumor, which did not have a lot in it. And you can see that even between 2018 and 2020, we had, of course, some data regarding larbactidine, and down to 2024, which is the Adriatic study, adding IO as a consolidation, and it was for FDA approval. So the key points regarding it, that do we have any advance on extensive stage? We can see that it's the standard of care start to be evolving. Tarlatamab can be a preferred second line after larbactidine, now going to as a maintenance and going to the first line. In selected patients, we can intensify, and we'll focus on this part as larbactidine to be in maintenance therapy, and the emerging, of course, DLC 3 target therapy show promising. So this is the standard of care, what we are now, which is the chemoimmune therapy for the patient who presented initial chemo-naive patients and with platinum plus etoposide, and the second line until the data coming, which is the topotecan, larbactidine, and tarlatamab for the patient with progression. And this is the study, what we are talking about, which was launched in last ASCO this year, and it was presented by Eloy Pazeras from Spain. And you can see all the big names also there, Solange Peter, Stephen Liu. So it was North American, European study, and the study, it's mainly looking at the patient who responding to the treatment. And the IMfort demonstrated statistical significant and clinical meaningful. And when you look at the study design, it was mainly patient, no prior chemotherapy, extensive stage, and no CNS involvement, and performance status 0 to 1. The patient was including about 600 patients, and the patient who have a response, meaning that CR, PR, or a stable disease with good performance status, those patients will be randomized to maintenance larbactidine plus atezo, and larbactidine was 3.2 milligram per meter square, and the atezo it was 1200 milligram per meter square Q3 weeks until this progression, and the standard arm it was atezo, as we know that this is the standard for this patient. So putting this in perspective, so the patient who is initial have a response, and so they will be stratified to maintenance with this combination. The primary endpoint, it was PFS and overall survival by the independent review. And the secondary, it was response rate, disease duration, and the safety. And we look at the stratification here, the performance status, LDH, presence of liver metastasis, no prior history of PCI. Looking at this data in perspective, we can see that we started with 600 patients, and almost 170 patients, almost quarter of this group, they didn't show a response, and it was not eligible for the second screening. So it's almost like 500 patients, they were on this group of patients. And we can see that 7 patients never started treatment, 82 discontinue, and almost 88 not randomized after induction. Looking at the patient criteria, we can see that the majority of patients were male, 62%, liver metastasis, about 40% of the population, time to induction to chemotherapy, it was 3.2, and the CR, PR, and the patient who got response, which is really impressive, it's 87%. We know that a small cell patient, they have initial good response, and the difficulty of the disease that those patients, they cannot keep this response. And so they have initial responsive, and this is interpreted with either by IMpower 133 and even here with IMfort as well. Looking at the PFS, and this is a primary endpoint, you can see a significance between the standard arm, which is atezo versus atezo plus larbectedin, and it was in favor for the examined arm, which is larbectedin plus atezo. You can see that the PFS, the median is almost double, 5.4 versus 2.1, with hazard ratio here 0.54, significant visual and also numerical. And you can see the p-value 0.001. So, and you can see that for 12 months, it was almost double, 20% versus 12%. And for 6 months, it was more than triplet. It was 41 versus 18%. Looking at the subgroup analysis here, you can see that all patients, they have a response. Either patient with tobacco history, liver metastasis, good performance status, and the high LDH or liver metastasis, those patients, we can see the hazard ratio between 0.56 to 0.53, mean that those patients, they have a significant response for this population. Not only the PFS and the overall survival, it was a secondary endpoint. You can see that 13.2 versus 10, so it's almost gaining about 3 months. And the hazard ratio here is 0.01, the p-value 0.01, and the hazard ratio 0.73. And you can look at the tail of the curve, the patient who responded initial, they keep continuing the response, and after a year of maintenance therapy, it's 56 versus 44. And we can see that even shouldering for the patient who received atezo alone, it seemed that larbectedin plus atezo has a synergistic effect, and this is keeping with the patient data as we can see. Looking at the details, you can see that the induction treatment giving about 3.2 months and followed by the maintenance, and this is the gaining regarding the difference between the two groups. The subgroups, we can see that all the patients, they have a response as well, irrelevant of the performance status, LGH, and even about 10% they were having PCI as well. And here you can see that the partial response here, it's about 17%, comparable to 9.9, and the stable disease, it's 54 versus 37. So it's clear that the combination added to the response, either the partial response and stable disease. And you can see even the CR here, 2.3 versus 0.5, and the duration of response, it was in favor for the combination 14 versus 11 on this group of patients. How about the subsequent therapy? You can see that either subsequent therapy here, chemotherapy, immune therapy, or target therapy, it was in favor mainly for the combination. And the toxicity profile, actually, of course, it's higher on the combination, but it's down that this combination doesn't show the patient with grade 4 or any serious discontinuation, about 6.2 versus 3.3. So it seemed that this combination is tolerable as well. And there was no serious or death incidents as it was reported by the investigators. Looking at the types of the serious events and the toxicity, the nausea, anemia, fatigue, and depressed appetite, of course, added to the immune therapy. And here the febrile neutropenia about 1.7, comparable to the atezo, which is 0%. This is a conclusion by the primary investigator. IMfort demonstrated statistical and significant meaningful regarding the PFS and the OS, and hazard ratio here of 0.54. We can consider that the combination of maintenance is a standard of care, and changing the landscape, adding to the efficacy of this group of patients. And IMforth is the first phase 3 study which show PFS benefit and overall survival for this group of patients considered as a maintenance. Looking at the depths, we can see that we have to know that this only can be given to the patient who is responding to the treatment, either a stable disease or partial response. And of course, the toxicity should be considered as well. We don't have a specific markers to stratify the patient who is responding or not, but you can see that from the second day, the treatment now is the primary maintenance here, lorbactidine plus atezo for responding patient. The landscape was changing, and this is fit to the title of the session today about changing the landscape of lung cancer. So the landscape of small cell is also changing based on this study, and the study, it was published in Lancet on the second day of the presentation. Thank you very much for your attention.
Thank you, Dr. Thank you, Dr. Mervet. It was excellent abstract. We'll move to the last talk. Our guest speaker from Spain, well known to everyone, Prof. Ignacio Gilbazo. He is a known figure in the field of thoracic oncology. He is the head of the Department of Oncology at FITAS Institute of Oncology in Victoria, Spain. He is also a professor of medicine at the University of Valencia and served as associate editor for the Scientific Journal of Molecular Cancer. He published more than 125 articles in top-rated scientific journals. He can enrich us with a topic about the opportunities in managing advanced non-small cell lung cancer. Prof. Gilbazo.
Thank you very much. Let me know, please, if you are able to see my screen now. Okay, I believe you see it. So thanks very much for the introduction, and really thank you for having me once more in this incredible series of meetings focused on lung cancer. And for me, it's really a privilege to have this opportunity to tell you very more about the antibody drug conjugates and how this new tool may be implemented in small cell lung cancer paradigm treatment, as we've just seen from a beautiful presentation by Dr. Mervet. So let's see if this actually works. So these are my conflicts of interest. And this is the outline I will then try to cover with a brief introduction to small cell cancer, trying to focus later on the introduction of antibody drug conjugates, how they actually work, and what is the structure, because this is a completely new weapon that we have, and we might not be much related to this. And finally, what is the actual role of these ADCs in the management of the small cell lung cancer? So it's something that you all but I think it's important to bear in mind that for the last few years, we've witnessed how the molecular subclassification and pathological subclassification of small cell lung cancer has tremendously changed thanks to the Dr. Rudin's works, right? So this is, I think, an opportunity to better know what the treatment disease is, how this disease can be actually targeted in a more advanced way. And probably it is also an opportunity to find potentially new antigens that may serve as targets for the ADCs as well as other antibodies, as we will see in a minute. So I think we have to keep in mind that molecular subclassification is not just something that can actually predict how the different treatment modalities may work, but this is also an opportunity to reconfigure the antigens, the targets, and the potential new drugs that we may be using in this hard to treat disease. And as I said, hard to treat disease, this is something that very much reflects how hard it is to treat patients with this histological subtype of lung cancer. And probably this is very much optimistic since it says that the 5-year survival rate is around 30 to 10%, depending on limited or extensive stage disease of the small cell lung cancer. In our hands, normally it is much less than that. At least it's been much less than that for many patients. And I think now with the results that we've seen from Dr. Mervat and probably what other new drugs may build upon that, we may finally change these dismal outcomes. So for a long time, the therapeutic advances in the small cell lung cancer were related to mainly different types of radiation therapy given on our patients. So not much about systemic oncology therapy. But we've seen that for the last 5-6 years, this has tremendously changed. And we've seen how first anti-PD-L1 inhibitors such as durvalumab or atezolizumab in combination with chemotherapy first line for extensive disease, later lurbinectedin, trilaciclib, and more recently tarlatamab, or even durvalumab after chemoradiation in limited stage disease, very similar to the Pacific trial protocol, but in small cell lung cancer, have actually been approved and have changed the landscape. As Dr. Bomer presented earlier.
Please hold on, close. Dr. Ignacio, please hold on. There's a technical issue with our main PC. Hold on, please.
Okay.
Let's get disconnected.
So in any case, this is a slide that you've already seen from Dr. Mervat's presentation, showing the classic treatment paradigm and standard for first line and second line therapy for small cell lung cancer patients. And we've seen also how this has actually changed. So should I continue now?
Yes, please. Please move backwards.
All right. So we were here saying how therapeutic advances in the very beginning were mostly related to different radiation therapy protocols combined with chemotherapy for limited disease, and what the role of whole brain irradiation was for these patients, or even the irradiation in the thoracic disease for extensive disease or extensive stage. But in the last 5 to 6 years, this has changed with the new standard treatments coming from the systemic therapy field, such as the anti-PD-L1 inhibitors, atezo or durvalumab, combined with chemotherapy and then the maintenance, but more recently lurbinectedin, trilaciclib, tarlatamab in pretreated patients, or even durvalumab after chemoradiation in limited stage disease. And of course, the INFOR trial that Dr. Mervat just presented will very soon also be considered a new standard for the maintenance setting, right? But this becomes considered the classic treatment paradigm. And this, as already presented, is probably the new landscape, and we consider lurbinectedin associated with immunotherapy in the maintenance setting as a new standard, but also second line for T-cell engager, tarlatamab, which is also an antibody. It is not an ADC, it's not an antidrug, conjugate, but it is a BiTE. It is at the same time targeting the lymphocytes and also the tumor cell, so it's able to put in contact directly the tumor cell with the lymphocyte, so the lymphocyte can be activated and combat the tumor cells. And still, we may have a third-line therapy with topotecan or lurbinectedin, and probably there might be something else coming. So the question here would be, what is next coming? So probably different antibodies that are being developed currently against small cell lung cancer and other tumor types might be the answer. Not only restricted to this, but probably this will be changing the paradigm. And among them, as you can see there is an important race in order to find the perfect antibody drug conjugate being able to change the life of our patients with extensive disease, extensive stage small cell lung cancer. So what are antibody conjugates in fact? Well, I think this is a very well-known cartoon showing how we are talking about antibodies. That is right. That is something that we all know. But at the same time, there are some peculiarities that we need to know. So we have also a linker, as you can see here, which is going to be binding the antibody per se to a cytotoxic drug, what we call a payload. And it is important also to see how this part of the antibody is going to be targeting, is going to be binding to a tumor cell surface antigen. So it is important for any drug development in this setting to know what potential antigens might be expressed in different tumor types, so we can direct those antibodies against those targets. And then, as I said, we may have a linker, and we need to have a linker and a cytotoxic drug. In a way, it is also important to see how the manufacturing actually works. It is not as simple as many other antibodies that are just synthetically produced, but in this case, we need a cell culture, we need a purification, we need also to link the antibody to the linker and the linker to the payload, to the drug itself. So it's not that easy, but it actually works very well. And how actually this new weapon acts on the tumor cell itself? Well, as we mentioned before, we are going to have this ADC that will recognize and bind to a cell surface antigen in the tumor cell. That has to be specific from the tumor cell. It cannot be something that is widely expressed in normal cells, because otherwise it would be so toxic. And the whole compound is going to be internalized in the tumor cell, as we see here in this vesicle. And at that time, there's going to be a release of the different molecules of the payload that will be able to be already inside the tumor cell and act on the DNA and create or produce apoptosis of the tumor cell. Here it says microtubule inhibition. Okay, that is the most widely used payload, but it's not the only one, as we will see in a minute. So in a way, we are seeing this is what we could be considering a Trojan horse. So we are entering silently in the tumor cell using a door which is open to us. But at the same time, we are being able to release the soldiers inside the tumor cell, inside the city, to be able to destroy the cell from the very inside of the cell. And this is probably the most interesting part of the way antibody drug conjugate works. But I think it's important to drive your attention also to consider that the same way we are directing antibody drug conjugates to tumor cell surface antigens, we may do very similarly with other tumor-related cells. Why not targeting tumor vasculature, for example, using the same strategy, or even other fibroblasts or other stromal cells associated with the tumor microenvironment. So this is probably something that is just starting, but I think we have to keep an eye on this because probably we'll be able to see different generations of ADCs targeting other cells apart from the tumor cell with very good results. And this is just a timeline of how ADCs have been developed over time. From the very beginning, the magic bullet concept by Paul Enrich in 1910, but more recently in 1967, the concept of ADC was firstly presented. So this is not a new idea. What is new is the way we've been able to land this concept with real antibodies being able to actually target tumor cells in the reality. So what about ADCs in the management of small cell cancer? Are we ready for prime time? Well, I think we have to consider, non-small cell lung cancer is in a way the big brother of small cell lung cancer in terms of drug development. So if we look at how non-small cell lung cancer has been developing ADCs, we see a big number of different strategies, different antigens in the tumor cell surface. We have TROP2, but we also have HER3, HER2, CEACAM5, c-MET, etc. And the truth is that we already have some of these drugs that are approved or very soon will be approved against non-small cell lung cancer. So the question is, what about small cell lung cancer? Are we really far behind, or are we approaching fast? Well, if you see this chart, this table, what you see is different potential targets. So we are considering also HER3 or TROP2, very similar to what we've seen in non-small cell lung cancer. But at the same time, we are considering other targets such as B7H3. We have mesothelin, which is important, especially in small cell lung cancer. We might have also folate hydrolase 1, etc. So this is, or even fibroblast activation protein alpha, which is again very much expressed on the cell surface in small cell lung cancer. So this is just evolving. We have different payloads. Most of them are DNA topoisomerase 1 inhibitors or microtubule inhibitors, most of them. Not all of them, but most. And there is very well summarizes the new kids on the block that we have. Roboti, lorlatinib, sacituzumab govitecan, very well known in many other tumor types as a good ADC, potentially, but we also have some other new drugs also. So some of them have actually been discontinued, such as the AB001 drug, but due to futility or high toxicity. But some of others are still in the race. And here I have one which is especially interesting that has been developed in this phase 2 study for patients previously treated with extensive stage small cell lung cancer. Since it is a phase 2 study, it actually compares 2 different drug doses, higher dose, lower dose, and the overall, the primary endpoint was overall response rate, as you can see here. This was presented at World Lung last year. You know that we are about to inaugurate World Lung 2025 this evening in Barcelona. That's why I was late to this meeting, because I was flying from my hometown. So sorry about that. And at that last year's meeting, what we learned was that for the higher dose, we had a very, very tremendous overall response rate of nearly 55% in a highly pretreated, hard to treat, extensive stage small cell lung cancer population. So I think these are really great results. And as you can see here, we have also a disease control rate of nearly or more than 90% with the high dose. This is, again, something tremendous that we can step in for in this setting. And not only that, but also we can see how the progression-free survival was more than 5 months, and the overall survival was approaching 1 year, which, and again, for extensive stage small cell lung cancer after prior treatments with chemo plus immunotherapy, or even more lines of therapy, because 3 lines were actually considered in order to be recruited to this trial. This is really outstanding. In fact, there was a press release earlier this past month in August, saying that ifinatamab deruxtecan has been designed as a breakthrough therapy by the FDA, so it might be fast approaching to the approval. And this is based specifically on this trial and the updates that will be presented tomorrow in Barcelona at the World Lung. So I'm really excited to be witnessing how this actually develops. Other drugs probably not still that far developed and close to approval. We have the Artemis trial, for example, early phase, with, again, extensive stage pretreated patients, again, higher dose, lower dose. And what we see is even more important overall response rate, ranging from 50 to 60%. So something really outstanding. We know that in early phase clinical trials, the results might be more striking, and then phase 2 goes down a little bit. And if we go for phase 3, we might actually have a drug that actually never gets to the market. So I think we have to be cautious with these very preliminary data, but I think they are really promising, and we have to keep an eye on it. We have at the same time over this is control rate of more than 95% with the higher dose, and overall median progression-free survival has not been reached yet for the higher dose. So we'll see probably in ASCO next year, probably, or even European Lung Conference in the spring next year, we might have more elaborated results. We also have this other phase study with sacituzumab govitecan, a very well-known ADC targeting TROP2. This is a classic drug already that has been used against breast cancer, non-small cell lung cancer, and other tumor types. And in this phase 2 study, open label, what we've seen again is a really interesting overall response rate with a good number of confirmed partial responses. And so I think we have to consider also this drug as a good option, and probably the overall survival and the median PFS are even more striking, with more than 1 year overall survival for heavily pretreated patients. Again, this is a hard to treat population, and we still see this number of overall responses and PFS and OS. Of course, with ADCs, tolerance is always a challenge, and you may very well know that for breast cancer or for non-small cell lung cancer, some of the drugs are highly toxic, mainly for diarrhea, fatigue, neutropenia, constipation, nausea, vomiting, alopecia. That is something that we're not really used to. Of course, for small cell lung cancer, we are, but not for non-small cell lung cancer. And these drugs are also being developed against non-small cell lung cancer, and some of them may cause alopecia. So again, I think this is a good challenge that we have ahead. So we have to put in balance what we can actually gain and what are the challenges in terms of toxicity, but the results are really, really promising. We have Robati again, as I mentioned before, probably showing not that good results as we just saw for ifinatamab or for sacituzumab govitecan. Median overall survival is even not reaching 6 months, so probably this still needs further development until being able to be launched. And in fact, there are 2 phase 3 studies with this approach that have been discontinued or terminated early due to their inability to fulfill the specified interim primary PFS and OS outcomes. So probably this is not the way to go. And finally, we have another drug, which is lorlatinib, with again very different in the sense that this is combined first line with chemotherapy. And so my question would be: do we consider the standard treatment just chemo, or is it already chemo IO, right? So if it is chemo IO, probably this design was not very interesting. We have to consider this is 2017 when the paper was published and the drug was developed. So probably this is why this is explaining how the standard at that time was not Atiso or Darba plus chemo, but now this should be rethink in the way that probably is again challenging toxicity, mostly hematologic, but also gastrointestinal. And what is the future of ADCs in general, and also in particular for small cell lung cancer? Well, I think we have to consider that probably we need to think of different targets, so different antigens in this tumor cell surface. We also need to think of different payloads. Probably we need more active and less toxic drugs. This is important because of the challenges that I just mentioned. And there are some ADCs currently that, in fact, are using as a payload an immunotherapeutic drug. So this is also interesting to see and to see how it actually develops. And probably new linkers that are also more potent in order to make sure that the drug is released as a whole when it actually reaches the inside of the tumor cell. So in conclusion, I would say that also small cancer still represents a really hard to treat condition. Over the last few years, some new drugs have been developed and approved with success. We have the ISO, we have lurbinectedin and tarlatamab. In different also strategies for extensive disease, for early advanced or locally advanced disease, as we just mentioned, in the maintenance setting. Well, ADCs are relevant anti-cancer tools already for many tumor types, including non-small cell lung cancer, but currently there are no ADCs approved by FDA or EMA against small cell lung cancer. Of course, we know that probably ifinatamab, deruxtecan, might be very close since FDA designated it as a breakthrough therapy. New generations of ADCs are still to be developed, probably using new payloads, new linkers, using as a target new antigens. So thank you very much.
Thank you so much, Prof. Del Paso, for this really elegant presentation. And if you allow me just to ask a question, usually there is one concern about small cell lung cancer. As you mentioned, usually the phase 3 trials can be very disappointing, and there is one concern about small cells that there is high turnover. The cells respond initially and later on disappear and then re-show again. So maybe there will be some sort of a change in the receptors with the eruption of a new relapse. I mean, cells will lose the initial target and then will gain another one. This is a concern, and how can we manage this?
Mm-hmm. Yes, I think you're right. I mean, we have to contribute with, especially with the really early phase clinical trials. At the same time, we've seen and we've witnessed how many drugs have been conditionally approved by FDA and EMA according to early phase results, mainly phase 2 clinical trials and some phase 1A/B clinical trials, especially in the field of immunotherapy. And in most of those contexts, the drug has finally been approved according to data more in more advanced clinical trial design settings, right? I think when we are considering small cell lung cancer as a really hard to treat condition and as a orphan, let's say, a disease with not really many advances in the last years, I think it is worth it to consider early designation or early approval, at least conditional until the drug is further developed, but not to impede our, current patients to get some benefit from these new drugs. So we'll be cautious, but I think it is worth it to approve them early, at least conditionally.
Thank you. If you allow me, Dr. Turki, to ask another question, Dr. Mervat, all of us, we know that small cell, as I mentioned, is the graveyard of the clinical trials. And so whenever just to find some sort of minimal improvement, we became very delighted and we try to adapt. Now putting too expensive medication in the upfront and the gain, although it is there statistically, but you think from, and let be pragmatic, this improvement worth to change the treatment paradigm in the first line?
Okay, you can hear me now? Okay, perfect. Thank you, Agnesio. Was great talk. Thank you. So it's a great question, Dr. Ahmed, because when we are talking about a difficult disease and we didn't move a needle within many years, and in the last 5 years we do have some changes. So this needs to be on perspective that we don't have much regarding the small cell, and so the point of improvement regarding the patient disease control, stability, and the partial response. The combination, as you pointed, there is no much. We are talking about 3 months, and also the duration of response. There is significance comparable to the single agent. So we are trying to improve first line and the maintenance. And also we are talking about the second line moving now to the first line and tarlatamab. So we are moving from the sequence of therapy, changing the first line, even it's not much, because a small cell, it's not the disease which have microenvironments, which is those patients different treatment, it was negative regarding the clinical trials and the data. So you are putting important points regarding the cost and also the toxicity profile for the patient febrile neutropenia. We can see that it's higher in the combination. But on the other side, selectively, we do have about 80% of the population, they were responding. And so you wanted to maintain this patient, adding this. So you need to be selective regarding the patient, will give them the combination, good performance status. Still, we don't have a specific biomarker to recognize the patient who is responding more, but it's considered a move or a slow step in a disease we didn't have much. So I will vote that we may consider it for the patient selectively, not for all the patients. Specifically that when we are talking about small cell, we are talking patient who progress rapidly and also CNS involvement. And so it's considered a step. Thank you.
Thank you. Do you have more questions? Okay, Prof, I have two questions regarding the ADCs. The first question is,
you can hear Dr. Turki?
Yes.
Here now. So, Prof, we have two questions about the ADCs in small cell lung cancer. So, number one is there is now the increasing talk about dual payloads. So, basically targeting two targets in the same time. Do we have any success? Is it associated with higher toxicity? Second question is, what is the efficacy in patients with, or let's say, are these drugs preventing or reducing brain metastasis? There is a risk of failure, small cell in brain.
Mm-hmm. So I think, thank you very much for these excellent questions. The first would be, all right, what about toxicity when we are targeting more than one target at this time, right? We know this is something that has a risk, and it comes with a risk of high toxicity. And the truth is that this is something we've seen, for example, with amivantamab in EGFR positive non-small cell lung cancer, where we are targeting EGFR and MET. We are having toxicities associated with the classic or the class toxicities due to EGFR inhibition, but also MET inhibition. We have hypoalbuminemia, for example, or we have oronychia, which is even higher. We are targeting MET. And at the same time, we're having also the EGFR, very well-known inhibition toxicities. So this is very similar. When we use BiTEs, when we use bispecific antibodies targeting at the same time two targets, we are taking that risk. I think we have to balance always what we are gaining, what we are losing, and especially for a so orphan disease, as I said before, right? With not any options, with not very good options in the long range, especially. So, of course, we have to see how we can minimize that toxicity, and probably the way to do that in small cell lung cancer is to select, as I said, antigens that are very specifically expressed only on tumor cells, not on other healthy tissue cells, because otherwise we may have really high toxicities. And probably, again, the payload is probably also important. So we just don't want to leave that payload, that cytotoxic drug to the inside of the tumor cell, but we want to do it in a way that is not going to be toxic for other tissues, right? And the second the second question was regarding, excuse me, I forgot.
Efficacy in CNS, to prevent CNS metastasis.
Yeah. So that's an excellent question. The truth is that we've seen, how, the paradigm was for a long time that antibodies were not able to cross the blood-brain barrier, right? This is something we were assuming, and we were thinking that it was a bigger truth, right? What we've seen is first that ADCs against breast cancer, for example, or non-small cell lung cancer with brain metastasis have actually good activity in the brain. So I think ADCs still have good activity. Why this is, we don't really know. I think it is not because they actually cross the blood-brain barrier, but because they are able to deliver or to act or interact with other tumor cells or other different cell types that are able to cross the barrier. The immune system probably also being activated, right? And at the same time, I think it is important to remember that small cell lung cancer CNS involvement normally works as a complete destruction of the blood-brain barrier. If you look at the brain images of these patients, you don't see the blood-brain barrier anymore. I mean, you see leaking the contrast everywhere in the brain, right? So and in truth, if you consider how chemotherapy, just chemotherapy works in CNS involvement of small cell lung cancer patients, first line, for example, we normally in my institution don't treat these patients with radiation upfront. We still work with chemotherapy plus immunotherapy, but in the old times we use just chemotherapy, and 90% of the patients also respond in the brain. So I think it is not a big issue at this point. However, we don't have good results or results that have been released so far using ADCs with regards to the activity in the brain. So you are right, we still don't know. I would assume that it's going to be working well in all that setting.
Dr. Nafisa, question?
My question to Prof. Gilvazio. Thank you, Prof. Very nice presentation. My question is, how do you select your patient for ADC? So we know that ADC known to cause ILD. In small cell lung cancer, we're talking about disease lung, usually poor pulmonary function tests, patient with COPD. So we're talking about disease lung. And now ADC is a very serious medication. ILD is in the breast, the toxicity, the percentage was around 20% in the best scenarios. So how do you select the patient in small cell lung cancer for ADCs?
Mm-hmm. So I think if you are considering, I mean, in small cell lung cancer, we have two big types of groups of patients, right? Those that are first limited stage disease that actually receive radiation to the lungs, right? And further, they develop metastatic disease and they receive other drugs, right? Those patients are at a really high risk of developing ILD in with ADCs and with other drugs, right? If you consider those patients, the other group of patients with showing at onset a metastatic advanced disease, those patients are not typically receiving irradiation in the thorax, right? So those patients would be better candidates for ADCs. Again, probably pneumonitis or ILD really depends on the payload, on the target, and how that target is expressed also in normal cells in the lung. So this is, again, a challenge and an issue. We know TROP2 is probably an antigen that is more widely expressed also among important number of healthy tissue cells. So, probably that's why sacituzumab govitecan might not be a good option. But still, we don't have data, about ILD for specifically small cell lung cancer patients, and with regards of those that actually received radiation therapy prior to ADCs or not. So I would be very cautious. I would make sure that the patient, when starting or being considered for ADCs, actually don't present any type of pneumonitis, even radiation-induced pneumonitis. If that is the case, I would not go for ADCs in this population.
So if I allow me, Dr. Turki?
Yes.
I have a question for Dr. Abdurrahman. Now, Dr. Rahman, before we were desperate, we don't have something to treat patient with exon 20 insertion, but now we have many medications. So is it the time now also that we start to do some sort of fragmentation and to check which type, for example, of the mutation? I mean, the duration of time between failure of the first line and the second line. So should we now start to, because we have some options now to dig deep again to know exactly what is the best treatment to be offered, one drug after the other, I mean, checking the type of the mutation and the duration between one drug and the second line?
Absolutely. Biological data will always help and will be more accurate to decide which treatment to go with. Problem with that, it's sometimes we don't really know much. We don't know what we don't know. Okay, so of course, if we have something that can guide us, this will help us to choose and to be more precise, especially in those difficult to treat mutations. And with the time we are learning, there is more than what on the surface in regard to even specification of the mutation. However, this is not the only factor, as you know. There is other factors, including side effects and patient convenience, and using oral medication, actually. It's very important. Going away from the thing that will keep the patient to the hospital and maybe causing reaction or maybe very critical side effects. You want really to go away from that and trying to use the best treatment with the least toxicity in the beginning. Okay, so in terms of exon 20 in particular insertion, which is we don't have really, we were desperate, as you said, and we don't have anything really to offer the patient other than classical cytotoxic chemotherapy. What we have now is a very excellent step toward the more precise treatment to those patients. I'm guessing we are going to move away from antibody to more oral treatment, tyrosine kinase inhibitor, if we have the data for that. And then maybe we'll choose different approach in the subsequent line of treatment. And of course, this will come with the data from other, driver mutations, not specifically for this.
Thank you.
I have the last question to Dr. Salim before I conclude. So you mentioned the oligoprogression and oligopersistent disease. So for oligopersistent disease, when do you think we should refer the case for radiation treatment?
And oligoprogressive disease, as per the protocols used and mentioned in the trials, they started the patient to chemotherapy for 3 to 6 months. And then they assess the response of systemic treatment. What kind of systemic treatment? And then you can define the disease as either oligopersistent or oligoprogressive disease. On my personal belief, this is a good timing to think of establishing a local, they name it in the recently MDT. When you think about a local treatment, the timing, I would say 3 to 6 months from starting systemic treatment. With time down the road, you will have an idea and a good belief and identification of the disease behavior. Either it's going toward an oligopersistent, which is not good in comparison to oligoprogressive, a progressive disease. And the chance of the physician to have the time and his discretion to decide when to shift for the next treatment, which they named in the trial TNT, time to next treatment. As now in the oligoprogressive disease, the best TNT achieved is 9 months, and the timing for switching or establishing, introducing the local treatments is 3 to 6 months.
We'll hand the mic to Dr. Ahmed to conclude.
Thank you so much, Dr. Turki, for just co-chairing this session. And really, I would thank the organizing committee for this really very elegant scientific gathering and all of this effort and the consistency and a very good topics they chose. And by this, just I end this session, and I would thank all the speakers, Prof. Ignacio Elpezo, Dr. Mirvat Mahfouz, Dr. Abdurrahman Shehri, and Dr. Salim for their elegant presentation, and I wish you a good day.
Thank you so much. Thank you, Dr. Ahmed. Thank you, Dr. Turki, for running this, the last session. I would like also to thank the speakers and moderators of the previous sessions. I would like to thank the organizing committee and everyone participated, especially the attendees who stay with us till late time. Thank you so much, and hope
hopefully we'll see you next year, inshallah, at the same time. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for joining our educational session. Please make sure to fill the questionnaire. We'll be sending you a questionnaire about how to evaluate this event. This questionnaire will be sent within the upcoming 1 or 2 weeks. After that, we'll be submitting your names. Those who are eligible will submit their details for CMEs. Thank you. Assalamu alaikum wa rahmatullah. And please make sure to have a look at our app where you can find everything, the past event, the future events, and all the related agendas, photos, and all advertisements. Thank you all very much and see you next time. Assalamu alaikum wa rahmatullahi wa barakatuh.